Good morning and welcome. It is truly a pleasure to see so many of you here with us today in person and to be joined by colleagues tuning in from across the globe. Thank you so much for making the time to be with us today to be part of this convening. At the WashU School of Public Health, our 6 research networks are not simply structures, they're the intellectual engine of the school. They convene scholars, practitioners, and leaders across disciplines, sectors, and geographies to take on the most pressing public health challenges of our time. Today's gathering is particularly significant. It marks the inaugural convening of Global Health Futures and represents our 4th research network convening overall, an important milestone as we continue to build both momentum and community. We're also energized by the breadth of this audience. Today, we are joined by more than 430 registrants, both in person and virtually, representing countries across North America, South America, Europe, Africa, Asia, and Australia, as well as more than 20 US states. This is exactly the kind of global, cross-sector dialogue this moment demands. With that, it's my distinct pleasure to welcome our Dean, Dr. Sandro Galea, to open the program.
Thank you, Courtney. Good morning. Thank you for everybody who's traveled to join us. Thank you for members of our WashU community, and thank you to everybody joining us online. Before I begin, I want to say my thank yous. I want to thank the intellectual architects of today's events, Dr. Salma Abdallah, Mark Huffman, and Victor Davila-Roman, from whom you're going to hear in a second. I want to thank the research network team, particularly Joshua Bogus, our Executive Director of Networks and Innovation, Professor Morven McLean, the Dean's Office, and our communications team who make events like this happen. Thank you everybody for making events like this possible. So I want to start with a bit of an observation about the moment we are in, because I think it's important to name the moment before we get into today's conversation. Global health, as we have understood it for the past several decades, is changing rapidly in front of our eyes. The United States has withdrawn from the World Health Organization. Development assistance for health is being reduced in this country and in many other high-income countries, and in many places dramatically. USAID, an institution, whatever one thought of it, was a cornerstone of how this country engaged with global health for more than 60 years, has been dissolved. The architecture of global cooperation that many of us came of age within is being dismantled, and what is emerging in its place looks more regional, more bilateral, and to my mind, considerably more uncertain. That is the world we are operating in. It seems worth saying so and saying so plainly, and yet, this is the part I want to dwell on, the case for global cooperation has never been stronger. It turns out that infectious disease do not respect borders. We learned this during COVID, and we'll learn it again, because the next pandemic is not a question of if, but a question of when. The challenge of equitable access to medications is, by definition, a global challenge. Pollution does not stop at national lines. Climate change does not stop at national lines. The health consequences of aging populations are unfolding everywhere at once. None of these problems can be solved by any one country acting alone, not a single one of them. So we are in a curious and difficult moment. The need for global cooperation is rising at exactly the same time that the institutions built to deliver it are being weakened. The question, and it is the question I hope this convening will help us think through, is what are we going to do about that? Not in the abstract, but concretely. What does global health look like in this new environment? Who leads? Who pays? Who coordinates? And central, I think, to this convening, what is the role of an academic institution like this one in shaping these answers? Let me say a brief word about why this conversation is happening here today at Washington University. We launched this WashU School of Public Health in January 2025. It was the first school at this university in more than a century. And from the start, we aimed to build a school with a deep commitment to local and global impact, with a conviction that the work ahead requires engaging with new disciplines and new partners across the public and private sectors, in our region and around the world. Today's convening, Building for a New Era of Global Health, is one of the gatherings of our 6th research network. It is the inaugural gathering of the Global Health Futures Network, and it's dedicated exactly to the kind of questions that I posed a few minutes ago. What does global health look like in a moment of transformation, and how do we continue to make a difference in it? So today, this convening to my mind is an opportunity to think honestly about where we are, to learn from one another, and to consider how this school and our partners in private and public sectors continue to contribute to global public health in an environment that looks very different from the one many of us trained in. I am genuinely grateful to everybody who has agreed to be a part of this conversation. And I am delighted that leading us into it is my colleague, co-director of our Global Health Futures Research Network, Dr. Victor Davila Roman. Victor is a professor of medicine, of anesthesiology, and of radiology at WashU Medicine, and is a member of secondary faculty at WashU School of Public Health. He has spent his career building bridges across disciplines, across institutions, across borders, and at this institution, he has long been really an intellectual leader in global health. Please join me in welcoming Dr. Davila Roman. Victor.
Thank you, Gbenga, for those incredible introduction words. Thank you, and also for setting up the stage for today's meeting. Good morning, everybody. Thank you for being here. It's a pleasure for me to lead this presentation today. I am Victor Davila Roman. I also co-direct the SPH Global Health Future Innovation Research Network, along with Salma Abdallah and Mark Hoffman, and our network manager, Joshua Bogos. As Dr. Gbenga said, the Global Health Futures is one of the 6 networks that work together within the Office of Networks and Innovations to cultivate interdisciplinary research. The overarching goal of our network is to catalyze research partnerships and to contribute solutions to today's and tomorrow's pressing global health challenges. The Global Health Futures work is focused on 4 core priorities. Number 1, to expand a community of global health scholars and partners within and outside of WashU. Number 2, to catalyze new areas of research by bringing together interdisciplinary teams to respond to major global health challenges. Number 3, to support researchers and engage with policymakers. And last but not least, to communicate and disseminate lessons learned to increase impact. This convening today marks the inaugural Global Health Future Network event and represents a particularly important one given the significant changes in research agendas that have occurred during the last year. Amidst what might seem a challenging and uncertain future, we see opportunities to build new programs and new paradigms for working together so we can continue to improve the health and healthcare of the poorest and most vulnerable around the globe. This is indeed a very important part of our mission. To continue these conversations, today, we bring together local, national, and international thought leaders from a wide range of disciplines and sectors. What I believe is common to all of us is a deep commitment to improving global and local health and health equity. And we do this work armed with the tools of epidemiology, implementation science, biostatistics, artificial intelligence, and others. I look forward to hear from our keynote speakers and panelists today their new ideas to work with colleagues in government, civil society, and private sector, and to seek out new collaborations to work with both local and global partners. It is now my great pleasure to introduce my esteemed colleague, Dr. Salma Abdallah, who will be moderating the first session. Dr. Abdallah is an associate professor at WashU School of Public Health and co-director of the Global Health Futures Innovation Research Network at WashU School of Public Health. Welcome, Salma. Thank you.
Good morning, good afternoon, and hopefully good evening, everyone, including those who are watching us from Australia. It is really my pleasure today to introduce our first keynote speaker, Dr. Benjamin Meier. Dr. Meier is a professor of global health policy at the University of North Carolina at Chapel Hill. His research examines rights-based approaches to health at the intersection of global health, international law, and public policy. His scholarship has examined how human rights influences global health governance of multilateral organizations, including the WHO and the World Health Organization at the United Nations. Dr. Meier actively contributes to the development of rights-based global health policy by serving as the chair of the Global Health Law Consortium, as a senior scholar at Georgetown University's O'Neill Institute for National and Global Health Law, and as the founding chair of the American Public Health Association's Human Rights Forum, and as a consultant to international organizations, national governments, and non-governmental organizations. Please join me in welcoming Dr. Myers.
Thank you for joining us today. We recognize that global health faces existential crises as the world confronts an unprecedented decline in U.S. leadership, U.S. authority, U.S. financing, limiting global health governance. And I've been asked to speak with you today in opening our sessions to discuss why we've arrived at this moment of political division in global health, what unprecedented threats now challenge our world, and how the world is responding to this U.S. decline, leading into our first panel today. And so thank you, Victor, Sandro, Salma, the entire Global Health Futures team, for inviting me to present at the start of this very timely convening. The world today is at a crossroads. As the United States has risen over the past 80 years to become central to the global health landscape. There, whoa. We're gonna go all the way back to the beginning. There we go. The world is at a crossroads, as I was saying. And yet the past year has shaken the foundations of US leadership in global health governance. And so I hope over the next 30 minutes to discuss the long rise of the US-led world order for global health, the rapid challenges that have been presented by this American decline, and the fundamental reshaping of our global health governance landscape amid declining American leadership. My presentation today reflects scholarship over the past decade. There we go. Developing 3 volumes to support the United Nations in advancing human rights and global health governance, to clarify the principles of human rights and global health, and to strengthen global health policies to ensure justice for a healthier world. It reflects my work as a professor at UNC in global health policy, as a scholar at the O'Neill Institute, and as the inaugural chair of the Global Health Law Consortium, bringing together legal scholars throughout the world to strengthen global health governance. And in focusing specifically on the global health governance implications of US policy, I additionally serve as the chair of the Consortium of Universities for Global Health's Advocacy, Policy, and Communications Committee. And our committee has worked, there we go, to develop academic resources to support classroom instruction on the global health implications of US policy, and specifically on the global health implications of the 2024 US elections. The challenging days since that US election have revealed the central importance of US policies for global health governance. With our global health column last month in the Journal of Law, Medicine, and Ethics, grappling with this first year of the second Trump administration. We have faced, as Dr. Galea said, sweeping challenges to global health over the past year. But in this uncertain moment, I hope that this rupture in global health governance can inspire a renewed examination of political determinants of health and can lay a foundation for the next generation of global health to prepare for the political fights to come. In framing this political fight for the future of global health, I hope over the next 30 minutes to examine the long history of US leadership in advancing global health, to clarify the magnitude of the present abandonment, and to lay a foundation for our continuing discussions throughout the day. Since the end of World War II, the United States has played the central role in bringing together the world through global health governance, with this evolving leadership seen through both our global health governance institutions under the United Nations, but also our bilateral assistance to specific countries. And yet, despite robust bipartisan support for global health, we've seen rising partisan divisions that have challenged U.S. engagement in global health. With this politicization of global health threatening global governance under the World Health Organization and dividing support for global health across political parties. We've all experienced, as Dr. Gbenga said, the consequences of these political divisions in undermining the COVID-19 response. But the United States sought through the Biden years to rise from the ashes of that failure and to heal a divided world to face future health threats. But we are now going back to a far darker time, of political division and international isolation, as the past year has presented sweeping attacks on public health science that has decimated our universities and research institutions, the abandonment of U.S. foreign assistance, as we discussed, under a new America First global health policy, and targeted efforts to undermine global health governance, leaving us exposed to future worldwide emergencies. Millions will die because of these political shifts. And I regret that the future of global health will depend upon American politics. This is not the way the world should work. But public health has always been political. And our failure to address these political determinants of health today, especially in the public health curriculum, should give us pause. And yet this neglect of political determinants of health long went unnoticed in our public health curriculum, as the very existence of global health did not hang in the balance of each presidential election, as historically the United States was a leader across political parties and across the global health landscape, with bipartisan U.S. leadership influential in shaping the modern global health order, bringing the world together in multilateral governance. The United States was the chief architect in framing global governance under the United Nations, binding together the world under the rules of international law, and establishing a basis for health cooperation under the World Health Organization. Although this new multilateral system for global health faced political challenges amid the divisions of the Cold War, this global governance system found new life with the end of the Cold War and the collapse of the Soviet Union, even as states continued to focus U.S. health efforts through bilateral assistance, using bilateral assistance as a basis to extend U.S. influence throughout the world. This preference for bilateral assistance has been there from the very beginning. And I hope that you'll consider why the United States government has long preferred bilateral assistance over multilateral engagement. This was seen first in rebuilding Europe after World War II under the Marshall Plan, and then with 1961 with the establishment of the United States Agency for International Development. And I added a brief video here that I hope plays well to reflect on President Kennedy's bold words at the establishment of this bipartisan and bilateral health initiative that is now gone.
The conquest of poverty is as difficult, if not more difficult, than the conquest of outer space. And we can expect moments of frustration and disappointment. But we have no doubt about the outcome. For all history shows that the effort to win progress represents the most determined and steadfast aspirations of man. Our problems are man-made, therefore they can be solved by man. For in the final analysis, our most basic common link is that we all inhabit this small planet. We all breathe the same air, We all cherish our children's futures. And we are all mortal.
Is this early advancement of U.S. power saved lives throughout the world that gave rise to an expanding ecosystem of government initiatives to advance global health, from NIH research training programs to CDC disease surveillance networks, as health policy became an explicit goal of U.S. foreign policy, even as it came to face increasing political divisions, with clashing views on global health across political parties. These begins, as with our neoliberal economic era, with the 1980 election of President Ronald Reagan, and with it, a staunch opposition to WHO initiatives. The Reagan administration first attacked WHO governance based upon the 1980s advocacy of a small organization called the Heritage Foundation, the same organization that would come to develop Project 2025 many years later. With this conservative advocacy attacking WHO funding and undermining global health policy in the 1980s in order to promote corporate priorities. Beyond limiting US funding to WHO, the Reagan administration's politicization of health resulted in increasing attacks on sexual and reproductive health and rights, with the so-called global gag rule, declaring that US bilateral aid could not be used for abortion-related care, and with opposition to LGBT rights, leading to the failure to take action to address a rapidly expanding HIV/AIDS pandemic. Millions died then, at home and abroad, and the band played on. But the United States re-engaged with global health, beginning under Democratic President Bill Clinton, even as US government engagement with global health shifted dramatically following the election of Republican President George W. Bush and the attacks of September 11, 2001, as the Bush administration shifted from a campaign promise of compassionate conservatism to address global health through a focus on national security, redefining public health as global health security to combat fears of bioterrorism and threats of disease invasion. And yet, despite the securitization of global health, we would see in this same moment the development in 2003 of the President's Emergency Plan for AIDS Relief, PEPFAR, an unprecedented Republican commitment to scaling up treatment and care for HIV, an increase in US government spending to rival that of any other global health effort, establishing a commitment to support HIV treatment throughout the world as a moral imperative, as President Bush said then.
Seldom has history offered a greater opportunity to do so much for so many. We have confronted and will continue to confront HIV/AIDS in our own country. And to meet a severe and urgent crisis abroad, tonight I propose the Emergency Plan for AIDS Relief, a work of mercy beyond all current international efforts to help the people of Africa.
The US, we would write, had become a singular force in global health. And under President Obama, we would see rising support for health systems in the global South, with a continuing focus on health security through the establishment of the Global Health Security Agenda. And yet at this moment, we would see the 2016 election leading to what we would call, in a moment of academic understatement, a profound transition in US leadership. In the first term, President Trump set out to reduce US engagement in international affairs. And this initial isolationism in US policy would prove cataclysmic for global health. The Trump administration immediately reduced foreign assistance in 2017, not in the same way we have seen today, but unprecedented at its time. in ways that threatened global health and human rights. In addition to resurrecting the global gag rule, President Trump went a step further than his Republican predecessors, expanding this policy from abortion-related services to all family planning services, and then withholding funding to UN initiatives to support reproductive health. Under this so-called America First agenda of the first term, the Trump administration rejected a range of international policies and organizations, withdrawing from several UN agencies and global efforts to address the existential threat of climate change. This US pullback from global governance in the first term would undermine efforts to address rising global challenges at the worst possible time. As my UNC students worked with me in the early days of the pandemic response to examine how populist nationalism was threatening public health decision-making in ways that destabilized the COVID-19 response at home and abroad. Facing this domestic failure in addressing a global challenge, we would see the administration doubling down on nationalist policies, banning travel and trade in ways that fractured the world at a moment when we needed to come together. And as the world ground to a halt, the president sought to withdraw from WHO entirely. The COVID-19 response showed the world the limits of America's nationalist approach to global health, leading for the first time to our efforts to begin to reimagine global health governance. But following a contentious campaign amid the COVID-19 response, the Biden administration came to office set upon reducing and reversing many of the impacts of the first Trump administration to revitalize a US-led world order for health. On President Biden's first day in office, he retracted America's withdrawal from WHO and reaffirmed financial commitments to COVID-19 vaccine efforts. Rebuilding US leadership in global health, we saw initiatives to support health systems, pandemic preparedness, underlying determinants of health, with the president making clear in his 2021 State of the Union address that
health care should be a right, not a privilege in America.
And drawing from this, we would see Secretary of Health and Human Services, Becerra, recognizing the importance of WHO governance.
Together, we must address racial, gender, and other forms of inequality, promote sexual and reproductive health and rights, and strive for equity across society. An inclusive global public health approach must include the voices of minorities, women, and lesbian, gay, bisexual, transgender, and intersex populations. We must continue promoting critical nutrition and vaccinations, fighting HIV, tuberculosis, and malaria, and addressing climate change. And we will do this together as a strong and agile WHO. Together, we will beat this pandemic. Together, we can help all people realize their right to health.
And so under this renewed US leadership to realize the right to health, nations came together under WHO to strengthen pandemic preparedness multilaterally through amendments of the international health regulations that concluded in 2024, and early negotiations that led to a WHO pandemic agreement which other nations adopted last year without the United States. These were inspiring, if fleeting, days of US leadership to prepare for future global health challenges. And as the 2024 election approached, we would again see the rise of populist nationalism. We would see a crossroads, and we would seek to support students in engaging with this moment, recognizing the global health implications. In the tenuous days following the election and before inauguration, we worked with US government representatives to highlight the benefits that the US was taking from WHO membership in a final fatal effort to prevent the incoming administration from taking the dramatic step of withdrawing from WHO. And yet the early days of the second administration made clear the cataclysmic shifts that the US government would be taking in the years to come. And we've sought to highlight these impacts, making clear the threat from the government's rejection of health science, attacks on human rights, abandonment of global solidarity. These US actions have upended US engagement across a range of health policies, as shaped through attacks on scientific integrity, where our new Secretary of Health and Human Services has undermined health research and spread health misinformation. The administration is not only disregarding scientific facts, but seeking to undermine scientific research itself, reshaping public health institutions through sweeping budget cuts, mass layoffs, executive orders, decreases in research funding, slashing support for our universities, both the research and the training that goes on here. The absence of evidence-based policy should give us pause, not simply because it is ineffective, but because it is wrong. It is immoral to develop health policy in the absence of health evidence. How do we engage with this immorality? Under NIH, the Centers for Disease Control and Prevention has lost sight of its global leadership in health science, as the administration has narrowed the focus of CDC programs, politicized health recommendations to meet ideological imperatives, nowhere more so than in our Secretary of Health's assassination with vaccination.
After reviewing the science and consulting top experts at NIH and FDA, HHS has determined that mRNA technology poses more risk than benefits for these respiratory viruses. That's why, after extensive review, BARDA has begun the process of terminating these 22 contracts totaling just under $500 million.
Under this anti-science, anti-vaccine agenda, we have seen the exclusion of CDC from global strategies and international health collaboratives. And facing these attacks on scientific freedom, it remains unclear how our universities and scientific institutions will be able to maintain their own scientific integrity as we limit science at home and abandon foreign assistance abroad. Where US foreign assistance has long been a source of American soft power throughout the world, this abandonment of US foreign assistance is diminishing US power and threatening millions. This abandonment, as Dean Galeo said, begins in the destruction of USAID, and this rapid end of humanitarian assistance, driven by a singular individual without congressional authorization, has resulted in the termination of thousands of aid projects and created a funding vacuum that no other actor has been able to fill. With the loss of this global health funding, millions have lost access to life-saving medical supplies, humanitarian services, medical interventions, vaccinations, and more. With global health leadership stripped from the Department of Health and Human Services entirely, we have seen the rise of the America First global health strategy under the US State Department, as the United States looks for direct benefits to the United States from any foreign assistance, as the United States now pursues bilateral agreements with recipient nations, as seen in the signing of the MOU here on the right side, conditioning global health assistance on access to critical minerals or data extraction, and eliminating programs that supported the most vulnerable throughout the world. Compounding this destruction of USAID, the administration has reinstated the global gag rule, frozen PEPFAR and the President's Malaria Initiative, with projected deaths in the millions each and every year. We should see these current actions of the US administration again as a moral failure, not just a technological challenge. Failing to see all people as equal in dignity and rights, destroying commitments that have been made to public health systems throughout the world, and undermining global governance. Launching this attack on the global order for health, the president, on his very first day, began the process to withdraw from WHO.
withdrawing from the World Health Organization, sir?
Ooh, that's a big one. So we paid $500 million to World Health when I was here, and I terminated it. China with 1.4 billion people. We have 350 to pay. We have, nobody knows what we have because so many people came in illegally, but let's say we have 325. They had 1.4 billion. They were paying 39 million, we were paying 500 million. It seemed a little unfair to me.
If you didn't hear that, don't worry. I'm not entirely sure what that meant. But this combination of formal withdrawals and non-payment of financial contributions across the United Nations system have had sweeping implications, as the United States, which has long been seen as the largest donor to many multilateral institutions, is pursuing renewed isolationism, burning bridges in its global efforts to promote public health, reminding the United States, as we have said before, that the United States is now on the outside looking in, unable to impact global efforts to prevent disease and promote health. And beyond this loss of US influence, these attacks have threatened the world as life-saving medications, medical assistance, and research initiatives disappear. We have seen the abandonment of our climate change efforts, disincentivizing other nations from reducing their own climate emissions and forfeiting US leadership to other governments, as the United States attacks the very global order that it created, reshaping itself as an expansionist imperial power with military attacks that have left the United Nations system paralyzed as nations face complex humanitarian emergencies, and the United States threatens war crimes, relinquishing America's moral leadership as a foundation for its global governance. And yet, despite these relentless assaults over the past year, actors are not falling quiet. We have seen actors rise to meet this US decline, and it will be necessary to understand the ways in which we are all being shocked at this moment. But amid the paralysis that many actors in global health have felt, advocates are beginning to consider the new world that will rise from the ashes of this moment, to consider the ways in which WHO, which is held together by a shoestring, is simultaneously being forced to cut its biennial budget by $4.2 billion, shifting its core functions to lower income settings, reducing its health programs from 10 to only 4, slashing its global workforce by over 2,000 staff members. And yet, despite this loss of its workforce and a dramatic scaling back of its programming, WHO has retained global influence under global health law, with its remaining member states coming together in May of last year to adopt the long-sought pandemic agreement together. The world is coming together in the absence of the United States. And the continuing work of WHO member states, should they be able to complete its final annex on pathogen access and benefit sharing, will allow global health policymaking to continue, whether in WHO, in advancing pandemic preparedness. We've seen the G20 adopting resolutions on climate change. We've seen the G7 addressing the implications of a One Health model to global health. And there is a future for global governance, but it will be necessary to reinforce these governance systems, requiring states to confront the dysfunctions of the UN system as we seek to streamline governance under the UN 80 initiative, as the UN commemorates its 80th anniversary, by reforming itself to face the challenges of the future, creating a fit-for-purpose global health system that will be necessary to address a world that does not see the United States as a leader and amid rising global actors. where the global health system has long remained overly reliant on a single nation, this one. Amid the loss of US funding, we are seeing new rising powers. No nation has been able to fill the void that has been left by the United States, but we are beginning to see other nations, including China, taking tentative steps. We see this in China beginning in its bilateral assistance under its Belt and Road Initiative, and multilaterally with China now joining the WHO Executive Board, which will soon select the candidates for the next Director General of the World Health Organization. And yet, despite this rising focus on international assistance from other nations, it will be difficult to absorb the shock that we have seen from the loss of US funding and support, leaving many low-income nations increasingly dependent on domestic funding to prevent disease and promote health. And while the shift away from foreign assistance has long been sought as a foundation to decolonize global health, the sudden nature of this shift has left domestic funding needs inadequate. How can we transition rapidly from a dependence on international assistance to rising domestic funding? And then finally, how can we bring the world together to address our common challenges if we cannot even agree on the truth? The truth eroded and trust in global health eroded by an administration that neglects health science, spreads misinformation, and raises doubts that leave us unable to distinguish the truth from fiction. Growing public and political skepticism has undermined trust in science. How do we communicate to the public in a way that will develop evidence-based policy? This will require us to strengthen global standards for health information, to ensure transparency in public communications, to improve health literacy across populations, and to protect the independence of science institutions under law. Addressing these challenges will require science-based leadership to confront an anti-science and anti-health movement, and raising, as I conclude, an imperative for political advocacy in global health education. Unnecessary suffering and death will persist because of this decline in US leadership in global health. But yet we have seen responses at the national level, at the regional level, and at the global level to ensure solidarity in facing our common challenges together. Amidst this destruction, how do we enable the policies that allow all people to realize health as a human right? How do we prepare students to meet what will be a political challenge to come? The Trump administration is not an aberration. It is a culmination of a political opposition to global health. And there is now a fight underway, a political fight for the future of global health governance. And yet, public health has long stood behind the fiction that health is not political, even amid a series of political attacks that give proof to this lie and have undermined our field, as we now face an existential crisis that threatens everything that we have built over the last 80 years. If we are to ensure global health through these difficult days and amid these rising political divisions, we must teach political advocacy to the next generation of global health practitioners, reshaping our global health curriculum to ensure that students have the necessary political skills to engage in this moment, to shape their careers, to develop healthy public policies, and to ensure that tomorrow's global health governance meets future challenges. Thank you very much.
Thank you, Dr. Meier, for this great presentation. If you have any questions, please hold on to them. We'll have some time for questions at the end of the panel discussion. So now I would like to invite our panelists to join us on stage. First, we have Professor Praskovia Nabonia, who's an associate professor and director of the International Center for Child Health and Development at the Brown School, and a secondary faculty member at WashU Public Health. We also have Professor Rodrigo Reyes, who's a professor at WashU Public Health, director of the People, Health, and Place Unit at St. Louis Prevention and Research Center. And last but not least, we have Kelly Saldana, who's executive director of ISPOR Institute for Healthcare Transformation.
All set. Well, thank you all for joining us today. I think I did not really provide a clear picture of all the amazing work that you're doing in my introduction. So my hope is for the next few minutes, maybe you'll introduce yourself, our panelists, as well as what are your perspectives for the future of global health governance? Just some initial thoughts before we start the conversation. We'll start with Kelly.
There we go. Sorry. Thank you to WashU for convening this great panel and event today, and thank you to Dr. Meier for setting the stage for everything that has been lost. I spent 25 years in the global health ecosystem, and so I come from this from a much more operational perspective, and from the perspective that whatever we do in global health governance going forward, there is an opportunity to rectify some of the distortions that were created in the previous global health architecture. So I worked primarily in health system strengthening, which was not particularly funded the way the US government funded global health. It was funded primarily by disease area, which led to silozation of programs. It was very difficult to coordinate across global health programs. It was very, very difficult for USAID and the USAID ecosystem to work on things like the rising burden of non-communicable diseases, of health system strengthening, and difficult to coordinate across programs when everyone was working towards their specific objectives and their specific results, and laser focused on those results, so it didn't allow to pull back and really look across other areas. I think, another issue is that the funding that the US government provided, while was very beneficial, also led to oftentimes unrealistic incentives and trade-offs. So, Dr. Meier mentioned the PEPFAR program was funded at about $6 billion a year, but still put pressure on countries in Africa to also increase their domestic funding for HIV/AIDS because they wanted to demonstrate sustainability, but that created unrealistic distortions on overall budgets within Africa that then couldn't go to other priorities when the HIV epidemic was already well funded. I think USAID also had very complex compliance and monitoring systems that took a lot of the funding off of the top and incentivized US-based organizations and much more mature organizations that could respond to those compliance requirements and that sort of thing, which really took away some of the ability of local organizations around the world to implement programs. And so my new role as the executive director of the ISPOR Institute for Healthcare Transformation, I really view my job as to set up this institute to really figure out how can we set up something that at least tries to solve for some of these issues. So ISPOR is a professional society. It spans academia, private sector, and government. I really think that bringing more actors to the table to have conversations around global health will help to facilitate conversations of different perspectives. ISPOR also works on health economics very broadly, from the development of innovations all the way through toward regulatory approval and implementation, and across the full range of programs, which I think offers an opportunity to really broaden the horizon. There is an entire ecosystem of global health work that USAID never touched because it wasn't one of the specific diseases. So everything across the board. I think also there's an opportunity, ISPOR is very focused on value assessment, and I think by having conversations around values and priorities really will enable the community to set the stage for what's important for different stakeholders and then how to work together to achieve those objectives.
Rodrigo?
1, 2. Well, thank you, Salma. Thank you, colleagues. My name is Rodrigo Reis. I have to disclose, I'm a professor here at the School of Public Health, but I have to disclose some of my biases. No, I'm a sort of an immigrant in the United States, born, raised, trained in Brazil, have done most of my work in Brazil, in Latin America, and then elsewhere as well. So my perspective comes from a sort of an immigrant man living in the United States, but trained in Brazil. So you have to take that into account. Secondly, my work focuses on cities and health, and I have been doing this for 20 plus years. I have worked with PAHO, now I'm the chair for the Global Engagement Partnerships with ASPPH, where we are trying to understand how schools of public health across the globe can sort of come up with a new way of determining I would call governance now, but I would call actually maybe architecture is the better word for now. And third but not least, no, my perspective is slightly different than Benjamin's perspective. No, I think, and I share that with many colleagues in Global South. No, the architecture on the globe for economy, health, trade, and the military has been designed by the United States. It has not been emerged from the United States. No, it has been designed to advance, one, military power, second, soft power. And as we know, public health is politics. And the politics in global health has been the soft power to be advanced through health as a way of entering countries to advance trade, military, and the United States presence. So I'm saying that because there's a strong sentiment about the damage that WHO has done, the United States has done as well. So there are many advances in global health in the last 80 years, but there's a lot of sentiments that this is the time for the Global South to try to understand how the protagonism of Global South can be emerging and not the colonialism thinking that WHO has been spearheading for a long time. So there's ambiguity in the sentiment at the moment. The lack of resources that is simply giving up from resourcing WHO and United States, and United Nations, is not only US. All countries in the European Union are not funding. This is the lowest funding rate coming from Europe to United Nations and WHO in 50 years. So this is a global problem. I think shifting the conversation, what the United States can do to elevate global health, to what the world can do to global health to have a new architecture, that's the way I've been framing things. And I'll talk more about how I think cities can be in the forefront of advancing that agenda. So that's my framing.
Thank you. Priscovia?
I share the same sentiments, and also to disclose, I was born in Uganda and trained in Uganda, which is in Eastern Africa. So, and my work is really focused around HIV prevention and HIV treatment among young people in Sub-Saharan Africa. So my perspective really sits at the intersection of what you just talked about, but also what Dr. Meier talked about, with getting rid of UNAIDS. I work with communities, I work with youth, I work with children. So I see firsthand how this has impacted the population that I work with. So the progress we had made in the last, over 30 years, we see that is being threatened. We see there's a threat around increase in HIV infections, increase in death of people who no longer have access to life-saving medication. We have a threat to HIV prevention programs that have been threatened, especially among key populations. Although, we are excited about new biomedical HIV prevention, but still that is costing a lot of money that we don't know how long that is going to take to get into the people in communities, rural communities that really need them. And the other part is also we had made progress around, preventing transmission among children born with HIV. But you take away those programs, it means that mothers do not have access to that prevention medication, and babies are going to born with HIV. And finally, around the systems, the healthcare systems, we saw very many people laid off, healthcare providers. And this also created a gap in surveillance, but also in referrals to care. So people who who are diagnosed with HIV, there is a gap. They cannot access HIV treatment. So my perspective really is how do we work to close those gaps around, we don't have funding, but how do we work within local and national and regional systems for us to be able to close the gaps that were previously occupied by UNAIDS and supporting agencies.
Thank you, Praskovia. So Ben, I wanted to come to you because I want to build on something Rodrigo said, and as I was listening to your presentation, I had similar thoughts. So I come from Sudan. USAID has done amazing work in Sudan, but at the same time, I worked at the Ministry of Health in Sudan, and I know I have colleagues here and across the globe where also you get told by USAID what should be your priorities. So we have mixed feelings. It's mostly that USAID was really helpful, but we also have some mixed feelings about how do we govern our structures within our countries. And I wonder if that some of the ambiguity, as what Rodrigo is saying, is coming from that tension. But knowing that tension, understanding that tension, how do you think about the reform that's coming up? The new WHO director election in the next year, UN turning 80. How can we hold two thoughts at the same time, saying that, yes, the existing infrastructure for global health before everything happening in the past year was very helpful for people globally, but at the same time, it had a lot of limitations. So how can we hold those two thoughts at the same time and providing space for people across the globe to have a space on the table so we can have a reform that doesn't have those similar limitations? Ben. Yeah.
So I think we can hold these two at the same time because it's...
Yeah.
Okay. So I think we can hold these two thoughts at the same time because at the end of the day, it is about process. The US-led world order was not ideal. It was unjust, it was unequitable, it was serving US interests at the expense of the world, it was not always grounded in global solidarity, but it was the order that existed. And the rapid abandonment of that world is the process that I'm most concerned about. That the United States had made commitments to public health systems throughout the world, and it abandoned those commitments. In an ideal world, the United States would step back steadily, as it had been, as we discussed, stepping back steadily from imposing its will on governments, asking about national priorities, working directly with communities, to realize this larger goal of decolonizing global health. But much like past decolonizations, in this case, the United States just packed up and left. And in that decolonized moment, chaos has ensued because there is nothing there to replace it. And so I think we need to concern ourselves with the process of making sure that we don't in the future have unilateral withdrawals that cause this chaos. And I think that should be center to the UN 80 initiative. And I worry that in this initiative to reform global health governance, so much of the attention is being put on efficiencies. How do we streamline initiatives? How do we make sure that we're able to do more with less? But at the end of the day, that's not really answering the most important question, which is why are we doing it at all? What norms are binding us together? Because if we can't talk about the equal humanity, dignity, and rights of all people, if we can't talk about equity, if we can't talk about solidarity as binding commitments, then all we're doing is we're talking about numbers and trying to streamline efficiency, but that will just, it won't prevent this from happening again in the future. So I think a stronger foundation for global health governance comes with binding commitments across nations, donor and recipient alike, and creates more of a partnership model under law.
And Kelly, so I read an article that you wrote recently, which I think is relevant to what Ben is saying, that in the existing structures that we had, we did have some tensions between country priorities as well as global priorities, and whose voices, whose costs, whose benefits actually get counted. So as you're thinking about this at ESPOR, but in other forums as well, how do you think we can restructure the global health system so that country priorities are being considered as the most important factor in decision making, that they are not just being taken into consideration, but that they're the main consideration and everything else falls into place following that?
Yeah, thank you. I mean, I think it is important to have shared norms and shared priorities, but I think it's also important to recognize that different actors are going to have different perspectives. And I think the way you solve for that is by transparently having those conversations. And so if you're looking at what are you valuing as a society from healthcare, and how are you prioritizing that? You could make an argument that, an HIV/AIDS epidemic is the most important thing. You could probably also make an argument that a growing burden of non-communicable diseases is the most important thing. And it really just depends on your perspective and what you're analyzing. But there hasn't been in the past space to understand that HIV, for example, is currently a chronic condition. Why can't we take learnings of what we've done in a system to support HIV and apply it to other chronic diseases and chronic conditions? And so I think by having upfront value conversations around why different actors are valuing different aspects and how they come to their prioritization conclusions, it can open the space for a more collaborative approach where perhaps one actor thinks HIV is important and is funding that, and another actor thinks that, non-communicable diseases, and they're pooling their funding. I think on the multilateral stage, this is very apparent to me in health system strengthening, which, as I mentioned, never gets its own sort of set of funding, and every program strengthens the aspect of the health system that's most important to them. So Gavi will strengthen cold chains for immunization. HIV will mostly strengthen supply chains for drugs. But you need to really look horizontally. And I think if you have those value conversations and understand what's needed as a foundation, it opens up the space for better collaboration across actors while being able to maintain true to their sets of priorities.
So Praskovia, and this is a pet peeve of mine, we can talk about country priorities, and those are important. But we know also that within countries, not all voices are created equal. And you work with youth who are impacted by HIV, and I assume, at least, if Uganda is at least a bit similar to Sudan, their voices are not usually the most heard voices in a conversation. So how do we make sure that the people who are mostly impacted, the communities that are mostly impacted, are actually part of leading that prioritization agenda, and not everything is either top-down heavy, donor-driven, but also country at large driven that might not actually necessarily address those specific needs of the communities that need the most support?
Thank you so much. So we need to flip the chart, to start from the bottom. So working in communities among youth who are affected by HIV and their families, it really gives you a different thinking about what we do things. So for me, in my work, programs that work, interventions that work, are the ones that are, where the recipients, they're supposed to be architects of those programs. They're not passive recipients that, you take an intervention, this is it, this is what will work. Because we all know that they know what they need, they know their priorities, and bringing them to the table is the best thing, for them, because they will then own those programs and interventions. But that also helps because it goes hand in hand with training, right? You have an intervention, you have a program that you have agreed on that it works, and then you have to build the capacity within those communities to be able to advance it, such that even if you leave, they are able to, to do their own work. Mechanisms around the training, community healthcare workers, village health teams. These are some of the things peer mentors or prep peers, like in some of my work around prep access and among adults and girls and young women. We are actually training women who are on prep to be able to deliver services, to be able to link these young people to health clinics. So going from, bringing the services within the communities, but also making sure that those individuals who are beneficiaries of those programs are the ones leading the charge of implementing those services, that's a very good way to go. So the other thing that we're thinking about and we are trying to promote is the integration of services. You may go to healthcare settings where you have 5 different programs. They're doing the same thing, but they're very distinct because this is funded by this funder, this is funded by this funder, this is funded by this funder, but you're all doing the same thing. So how about, bringing together the resources and integrate those services within, care? So services around HIV prevention, services around HPV vaccination, these have been all isolated around TB. But now within the funding environment that we have, we need to integrate those services such that, it's a one-stop shop. This is what is happening instead of funding different programs.
So then to do this, and this is actually a nice plug for Rodrigo. I don't know if you planted that, but that was a very helpful plug for my next question. So Rodrigo, you work with cities, and everything that Praskovia just said largely has to be implemented by local entities, city governments, city private or urban level private entities or civil society. So usually it needs multi-sectoral work that is not either at the national level or the global level. I know you work with cities, especially as the world keeps urbanizing, but what would be your thoughts that we actually take into consideration that on the ground, those are the entities that need to implement the work? How do we incorporate their ways of working within our global health structures?
No short of hard questions, right? So that's a good question. I think before I jump into the answering your question, I think we need to contextualize some of the last 80 plus years in this, what I'm calling architecture, not the governance. It has been defined in the United Nations, WHO especially, when the world was 30% urbanized. We are 55% urbanized, 70% by 2030, 2050. So the way you conceptualize later the governance for public health, locally and globally, has largely been informed by that conceptualization and focusing on malaria and tuberculosis early on, and now the world is very different. So I think first we need to reimagine how public health is happening locally, largely focusing on the social determinants of health. And why this matters, because the World Bank and the economic system was funding infrastructure that fundamentally changes social determinants of health. So cities, they can actually act more on the social determinants of health than the national government, because that's where we improve transportation systems, housing, water systems, and so and so. So I think that's the first part of my answer, Salma. We have to reimagine how global health happens locally through those infrastructural changes that cities can actually work on. And those changes are not emerging from the health sector. They are coming from the sectors outside health. So I have been focusing more in how what I'm calling complex interventions that's outside the health sector can actually improve health. So that's the first part. I think we need to integrate those, I'll call them interventions, but housing, transportation, zoning, water systems, as part of the health ecosystem in the cities. So that's the first one, and the conversation is just emerging now. Benjamin mentioned that the One Health conversation meeting happened this year, WHO. So that's the first one. The second one, we did a series of papers last year asking how cities reacted to COVID through local changes, focus on active mobility. And then we examined local policies that were implementing during COVID, changing routes, closing streets, changing those transportation systems. And there was clear advantage in the cities where the infrastructure was in place to cope with the necessities to help people moving during pandemic times. So there are local actions that we know that worked. So the second is not reinventing the wheel, but just seeing what has been done and has worked. So we have that documented. And the third one, the sustained changes we have seen after COVID in this series of papers, they happened when two things were in place. First, the infrastructure was in place, and when community engagement was advocating for the change to be kept in place after COVID was gone. Meaning, that the route has changed. Now we want to use that for biking or walking, or we need this new bus route here. So I think that it's a combination of the solutions are there, the community should be part of the implementation process, and then we just have to track the changes. We don't do that well in cities. No, you are doing some of their work. No, we don't have dashboards in cities tracking changes, policy changes. And the dashboards are largely related to biomedical outcomes. Now, how many people went visited the hospital? Vaccination distribution. The health dashboards in local health dashboards, they do not incorporate social determinants of health. So there's very little work that I can say has been done well with comprehensive dashboards, conceptualizing local health as something more comprehensive than only biomedical outcomes.
So then, this is a question for everyone, but thinking about your own perspectives and where you come from and the type of work that you're doing, as we think about the WHO, and there are a lot of change happened over the past year, but as the WHO tries to remake itself, what would you say this is the most important area they need to focus on, with the US withdrawing, but also with the increasing financial difficulties that organization has? And I know, Ben, you've done some thinking on this, so maybe we'll start with you, and if you mentioned it before.
WHO has a voice. Even without any money at all, it has a voice. It speaks for the global health community. It can speak truth to understand what is true and what is fiction in the context of health information. It can coordinate actors in a diverse global health landscape, and it can set norms. And at a moment when WHO is facing staffing shortages in its resources across countries, I've advocated within and outside of WHO that the most effective thing that it does is the least costly thing that it does. It's establishing global norms. As WHO looks back on its history, it sees the most important things it has done outside of eradicating smallpox is developing the international health regulations, finding regulations to bring the world together in responding to public health emergencies. In non-communicable diseases, it developed a framework convention on tobacco control to try to shift the tide of a global tobacco pandemic. And it's now at the cusp of developing a pandemic agreement. So I think WHO is strongest, not when it is providing direct services, but when it is establishing global norms. And I think that policy focus of WHO, which doesn't lend itself to the medical staff, but requires more political actors, more policy actors, more legal actors, is the most impactful thing it can do, particularly in a period of scarce resources, in a way to bind the world together in solidarity.
So I was going to say the same thing, and he said it much more eloquently than I did. So maybe just to take a different angle on where I think WHO has fallen short and continues to fall short and should recognize that, is WHO is inherently an organization made up of governments and member states. And the global health ecosystem is multi-sectoral. It's public, it's private, it's academia. most countries in the world are mixed systems where health services are delivered by both the public and the private sector. There's an entire industry of innovations and clinical trials that build up infrastructure around the world. And WHO has tried to convene across multi-sectoral. Sometimes they do okay at it, but they always default to the perspectives of governments and member states, which they should as a norm-setting organization. But they need to, I think, open up their aperture a little bit in having conversations and understanding perspectives of a much wider stakeholder group, and then recognizing that in those multi-stakeholder conversations, outside of their norm-setting role, they are on equal footing with other actors who are trying to figure out sort of the best intervention or the best approach to doing things, and to sort of show up a little bit more as a collaborator and not sort of the main decider in the room, if you will.
So that was a great way for me to answer this as well. I think the global health ecosystem is much more than WHO. I doubt anybody here is optimistic if anything will change in the next 5 to 10 years in terms of global health funding through WHO. I doubt you can say that firmly. Meaning, I question whether WHO is the right architecture for us to develop global health systems anymore. I think it became a dying body that has been largely defunded, and it has to be reimagined from the ground up. So can we afford 10 years to that to be in place or not? I don't think we can. So, but we have ways of enhancing the global health ecosystem through institutions, from cities, local governments, bilateral agreements, and people are doing that. If you see, Africa CDC has became such a major player last couple of years. So there is tragically this absence of this gigantic presence of the United States in the last decades. It's allowing other actors to emerge. So I think the call for action we have, and WashU and our network has, is what's going to be the place we're going to occupy in this new ecosystem. Because soft power is it's somewhere. It has not landed anywhere. We don't even know who's going to be holding the soft power, no tools at this stage. In the next 5 to 10 years, nothing will change fast. So I think we have to start doing alliances like we're doing. The ESPPH is working with partners in Europe. ASFRA in Europe, for instance. We are working with partners outside the WHO ecosystem. And other countries are doing the same, bilateral agreements. Cities will never replace a global structure. They don't have the power because cities are highly dependent of federal systems. In certain places, even more, because the governance, it reflects some of the more vertical, horizontal style of leadership in the country. So cities will never replace that architecture, but can be part of this new ecosystem. And I don't think we are paying much attention to that. So my call for us for action, that for us to think, is how we can be part of this new ecosystem and not just waiting for WHO to reinvent itself, combat anti-colonialism, and be funded again, and another big brother will come and fund heavily WHO. That's not going to happen. There's no question about that.
Scovia? I agree. I think the days of waiting for WHO to come to be our savior are long gone. If we learned anything from COVID, countries, especially from Sub-Saharan Africa, they were impacted a lot by COVID because we were waiting for those guidelines. So for me, for WHO to reinvent itself, one of the key things they should do is to really empower and integrate those regional bodies. So in Africa, we have the Africa CDC, which is at the core of advancing public health in Africa. So things around funding from member countries, things around innovation, encouraging innovation, manufacturing, testing kits and medical devices. So I think that WHO needs to look at these bodies, these regional bodies, as as complementary to what they're doing, as opposed to they're not competitions. So I think if we shift that understanding in that way of looking at these bodies, we'll be able to transform WHO.
Okay, so you and Rodrigo said two words that have mixed feelings about bilateral agreements and regional agreements or regional structures. And because I both see the potential behind those type of agreements, but at the same time, and Sandro mentioned this, Ben, you mentioned this in your talk, there are a lot of issues that require global work. They require global collaboration. Pollution is not going to stop within one city or one region. So just opening up the floor here, because I'm trying to get someone to help me with my own thinking about those issues. How do you feel about bilateral agreements and regional structures being developed? And how can we create a system where they're useful instead of being something that is just transactional, similar to some of the agreements we're seeing right now? Anyone?
So what we are seeing now in the world, the dismantling of alliances. The last time something that big happened was in the 18th century, when the colonial powers had alliances, France and England and Prussia and so and so. That was the last time we saw such a global change in alliances. So we should not be naive about the global architecture for whatever you can imagine now. The question should be asked now, is multilateralism dead or not? We don't know that, Salma, yet. But while we cannot answer this question now, what should we be doing right now? We should be looking for the resources we can, and the partners we can work with. So I don't think it's a substitution. I think it's complementary to the immediate needs we have, for the needs there on the ground, because the population there is now sick now, cannot wait for us to decide that globalism will be back in 30, 50 years' time. So I don't think it's a substitution, so it's not a yes or no. I think those are tools that should be in place for us to advance the needs we have, regional needs we have. I don't think we should be just giving up on thinking globally, guidelines, information, and largely guidance on what is important. But I don't think we should be waiting for that to be possible. And this is not possible today. We are seeing this, just turn on the TV to see what is happening right now. Right? So we have to be pragmatic in advance with the tools we have in place.
Ben, I know you probably have an answer. And Kelly, before we do that, we're going to start the taking questions from the room. I have a few more questions here online, so if you have any questions, please start lining up. We have 2 microphones here at the front. But then, Ben, you had an answer as well?
So I think there is a push now, amid the collapse of the global order, for a regionalization, a decentralization of global health. And I think there are 2 challenges to that. The first one you raised is that there are many problems that cut across regions. And the World Health Organization, for its flaws, brings together every nation in the world with one vote. As we begin thinking about public-private partnerships, regionalization, suddenly we have these country club approaches to global health. You can join, you don't have to join. And so we're going to see a bifurcation of the system into those institutions like the UN that can address global problems, and these sub-global institutions that may have greater coherence within themselves, but can address global concerns. And the second concern I have is that there are differences across regional bodies. The African CDC did amazingly well in the COVID-19 response because it sits under the African Union and there's political buy-in across the region for it, but not all regions have that coherence, have the same political bodies overseeing them, and so we're going to see divergences across regions where some will have stronger governance and by virtue of that, better health outcomes, and others will be left behind. And so the global system under the UN, for all of its flaws, seeks to ensure global problems get addressed and we address them equitably.
Kelly?
Maybe just quickly, I think when we talk about bilateral relationships, I think most people in this room have a mental model of funding flowing from richer countries to poorer countries. But I think if you think about it from a knowledge perspective, it's really important to make sure we're having space for knowledge flowing the other way, because there is a lot that can be learned in higher income countries from the experience of low income countries, community engagement being probably the prime example of that, but really sort of identifying ways where a bilateral relationship is not just about funding, but really also about how you learn lessons and how you develop and, and get the best of wherever that is and be able to disseminate it more broadly.
Thank you. Colleen?
Oh, it is on now. Hello, everyone, and hello, friends and colleagues. I'm Colleen Matar. I'm a professor at the School of Medicine with a secondary appointment here. I'm going to make a comment and then ask you a question as a food for thought. I will also preface by saying I'm originally from Lebanon. This is where home is. And then second, at one point in my life, in my youth, I worked for WHO. I understand its shortcomings. That's why I've been here for 10 years. I do want to bring up a point that back home, also for the region, and I really appreciate the comment about the differences between regions, the normative guidance that comes out of WHO is absolutely essential for the health system at every level. And I think that is really important not to forget. It is still true up until today. So WHO still serves that purpose. The other thing is that if we think about the global architecture and how WHO was really made in what it is now, I think everybody's familiar with the framework of engagement with non-state actors, or I hope you are, which really limits WHO's ability to truly engage with other stakeholders, including civil society organizations, academia, etc. So WHO is still effective in certain respects. I'll also want to give one very quick example. Right now, as you all know, there's a conflict in the Middle East. At some point, there's a region of Lebanon that was warned that it was going to be bombed. And WHO intervened so that the biggest public hospital in the country can be spared, and it was given assurances and it was spared. And there was no other entity in the whole world that actually intervened to stop that. Would have been a very big humanitarian issue. So right now, as we're talking about UN80 and the current consultation on global health, the reform, one thing that's being taunted with the WHO's, I would say downsizing is that academia is, and collaborating centers are going to have a much bigger role, or this is the hope that WHO will be able to engage with academia in order to fill the void in their own expertise that they lost. So my question to this brilliant panel and to the group, how can we in academia today at WashU Public Health and other great institutions position ourselves to truly be able to engage in a meaningful way? Potentially through the collaborating centers, but I also think that that's probably not the best way to do that, as it is quite restrictive. So how do we in academia engage meaningfully in the reform and in the future of global health? Thank you.
Thank you. Anyone?
I don't know if I have a full answer to that, but I'll take a stab. I think one of the things that I think USAID did well through its projects was the way that we set up global programs that were able to test innovations and innovate those in countries, and then work them through WHO and WHO working groups into normative standards, was really useful. And I think that is a role academia can play as research happens and research results come out. I think finding a way to use the results of those research and feed that into normative processes of WHO to set new guidelines and standards that then countries can pick up and implement is a key role. I don't know exactly how that happens, but I think that really should happen, and that's where academia plays a really important role.
Thank you, Colleen. And one thing we are doing right now, we are trying to understand what are the competencies and curriculum needs that we can develop for global health with this new sort of imagined word. So ASPPH is doing this in partnership with other alliances. We have in this global alliance, we have maybe 80% of the schools of public health in the globe, they are involved. So that's one, perhaps the easiest thing we can do, quote, quote, is understanding what the needs for the students working with global health today. And imagine global health as local health, with the global to local impacts as we have been defining lately.
And so I think the flip side of bringing evidence into WHO policymaking is using scholarly resources to assess the policymaking process itself, to create assessments of WHO policy in order to facilitate accountability for WHO action. And the two issues that you raised both involve WHO policies that are sadly not being assessed. The first is called FENSA, so it's the Framework of Engagement with Non-State Actors. And it seeks to limit the non-state actors that can work with WHO, because sometimes it's not easy to understand what is a real civil society organization and what is a front for the tobacco industry or a front for the US government. And so there need to be some standards, but we have no assessment of how FENSA is working out in facilitating meaningful participation of impacted communities. And the second is the SSA. So it's the System of Surveillance for Accountability for Attacks on Healthcare Systems. And WHO has a voice in stopping bombings of hospitals because WHO has a system that it's developed to monitor all attacks on healthcare systems. And WHO uses that data in order to raise its own normative authority to stop attacks on healthcare, seeing them as a violation of the right to health and international humanitarian law. And yet there haven't been real assessments of the effectiveness of using data as a foundation to prevent attacks on healthcare systems. So I think part of it is bringing data into the policymaking process, but I think there's also data after the policymaking process to assess its effectiveness.
Thank you. I know we're running out of time here, so I want to respect everyone's time, but there's one question online that maybe one person can try to answer here. I would be interested in hearing the panelists' perspective on the evolving global order in effect, how it's affecting biodiversity and the depletion of natural resources, and how these dynamics constitute some of the most significant and yet under-examined risks to global health. Any takers?
I'm not sure if I really follow the question. I think it's the connection between global health and biodiversity.
Yes.
And I think there's a clear answer. There's the One Health approach has been part of the conversation. Now, I don't think we are seeing global health imagined as a more comprehensive and holistic health concern. I see it, even the examples we saw today, Ben gave examples, and probably you'll see in the next talk. No, the examples we'll give are vaccinations, infectious diseases. We don't see many examples, chronic diseases, planetary health, One Health, infrastructure. So maybe there's less attention to that with tangible examples, and I think it's a flaw we can sort of overcome.
Great,
yeah.
Thank you. Ben, you seem like you have burning thoughts in 1 minute or less.
And I think as we begin thinking about the reform of the UN system, we need to recognize the interconnections across international organizations. And in addressing biodiversity, WHO has partnered first with FAO and what was originally OIE, but is now WOA, the World Organization of Animal Health, to begin thinking about these interconnections across plant and animal health. And it's now expanded to what's called the quadripartite, which now brings in UNEP to focus on environmental protection. And so part of the reform effort should consider these interconnections across organizations, not as a way of supporting efficiency, but as a way of recognizing interconnections across underlying determinants of health.
Thank you. Thank you to our panelists. We had really great questions online. Unfortunately, we don't have a lot of time to go through all of them, but hopefully you'll get a chance to ask those questions in the next panel. Thank you all. Can we give a round of applause to our engaging panelists?
This session will begin with a keynote presentation on global lessons for local health, and this will be followed by a panel on translating global insights for community health impact. Our second keynote speaker, Dr. Gbenga Ogedegbe, will be formally introduced shortly by Dr. Mark Hoffman, but I want to make a few personal comments about Gbenga, who I have known for about 20 years through our work on several large NIH research consortia. Gbenga was born in Nigeria, went to medical school in Ukraine. That's tough, right? Learning Russian for med school, right? Then from there, he went to New York for subsequent residency training in internal medicine. What I love about Gbenga is not only that he's very smart and insightful, but he's also nice, always cheerful, and oftentimes very funny. He is one of the most respected, prominent, passionate researchers in the field of hypertension. His research in both the US, in Ghana, and in Nigeria has been pragmatic and quite impactful. That's why funders like NIH, American Heart Association, and others have recognized his work by supporting his research for well over 20 years. I personally want to thank you, Gbenga, for taking time away from your busy schedule to visit WashU on this most important event today. Thank you. It is now my pleasure to introduce Dr. Mark Hoffman, who will be moderating the next session. Dr. Hoffman is a cardiologist and the William Bowen Professor of Medicine at WashU Medicine. He's also a member of the WashU Public Health Faculty, and along with Salma and me, he co-directs the Global Health Future Research Network at the School of Public Health. Thank you, Mark, for moderating the next session.
Okay, great. Good morning, everybody. It's my pleasure to introduce Dr. Gbenga Ogedegbe. Dr. Ogedegbe is the inaugural and founding director of the Institute for Excellence in Health Equity at NYU Langone Health. He's the Dr. Adolf and Margaret Berger Professor of Medicine and Population Health at NYU Grossman School of Medicine. His research on cardiovascular disease risk reduction has focused on evaluating models of care and interventions that address health outcome inequalities both in the US, Nigeria, as you heard, Ghana, and other places. He's a member of the National Academy of Medicine, and he's previously served as a member of the United States Preventive Services Task Force. He's a fellow of many scientific organizations, including the American Heart Association, American College of Cardiology, American College of Physicians, and the Academy of Behavioral Medicine. Please join me in welcoming the esteemed Dr. Ogedegbe.
So good afternoon or good morning. Good afternoon, almost in New York City. First, I have to thank Victor for actually getting me here. And I'm actually very excited. You may not see it. I think most of my excitement came out of last night at dinner. I had the best steak of my life and salmon all together. I didn't lick my fingers as I would when I was a kid, when you have good food. And so I want to thank Sandro for actually inviting me as well. I want to thank the directors of the Global Health Futures for having me here as well. And I hope that today, Sandro gave us a charge to think about, in this current space of public health reality, what should we do and how should we go about it? You've heard about the political determinants of health that Ben eloquently actually showed us from the political history of global health. And you've had the debate of should the USAID be here or how should we think about this? And finally, my hope is that I can help you rethink the question differently, because I believe that the way we should think about this has to be how we shift that question. So my presentation today, we kind of touch upon the work I do in that space, and then hopefully I'll end up with some sense of how we should move forward. You may ask the question, why am I here? I'm a physician scientist. But make no mistake, my heart is in public health. My mom was a market woman. My father was a retired clerk. And I was born in Lagos at the time when most countries in Africa were growing and having their independence. So I have a full sense of what that means. I was the founding vice dean for the Global Institute for Public Health at NYU that became the NY School of Global Public Health. So I understand that space very well. We wrote the procedures to think through what public health is. And finally, I served as Associate Vice Chancellor for Global Network. NYU is a global network university. We're in 11 campuses across the world. So I have a deep sense of what global health actually looks like. So back to my day job to think through what this looks like. My life actually depicts the whole sense of what health equity should be looking about. So these are my disclosures. I'm mostly NIH funding lately. I'm doing some work with industry. Why? Because global health health equity is on that onslaught. So the way I see it, you drive innovations and changes by using industries as well. So we'll assess the impact of the current admin on global health. I'll skip through that quickly because you've heard a sense of that. Hopefully we can talk about the consequences of the stalled funding in global health. I'll show you some figures of what that could look like. And then I'll end up by discussing what I think is the importance of reciprocal innovation. Going to that last question about, how should we refocus this question and this debate we're having here. So if you think about it, the numbers here shows you what is happening. PEPFAR, Presidential Emergency Fund for AIDS Research, 1.9 billion proposed cut, 2026. Already probably we'll see where that ends up. 80% of USAID funding for global health has been stopped. Some life-saving funding still exists. So I'm speaking mostly about Africa for the most part. Please bear with me because I think it probably relates to other places, but not as much if you think about it properly in terms of the regional focus of Africa. And then lastly, we know that WHO is, the US is leaving the WHO. You've heard a lot about that. What that really means is that we're looking at 500,000 to 1 million people that are estimated to die annually from the cause that we have. We've all written about this in different ways. It was existential about a year ago. But suffice to say that, we cannot talk about the lives that have been lost without thinking about the platform and the infrastructure that's been built for this already. So these numbers here just shows you some of those. And we're looking at the lives saved. We're looking at the people on highly active antiretroviral treatment. We're looking at babies that are born free from HIV. If you're African today and you live in Africa, you've been to Africa, you will appreciate that the reason Africa is not wiped out here is because we're a community, and that community is formed by people. So when we have births in Africa, we're building new communities. The median age in Africa is 19 years of age. Just pause, 1.2 billion people, 19 years. It's a big deal. Biden will call it a BFD. I think in this global structure we have today, it's important to think about what that means. And let that data just pause with you. When you look at what we have here in terms of the babies that are born free of HIV, and people are living longer now, when you stop PEPFAR or you stop USAID funding, you're going to have babies who are young with HIV. Now, I've created the existential crisis about if we stall the funding, what does it look like? I would argue that, we should not forget that when you look at the way we build systems around HIV care, the platform is the most important in my opinion, not so much the lives that we're changing. Africa is not new. Africa is not new to the idea of global crisis. We've been through that before, and we'll still be there. I think Meier put it well, still arise. We'll still be around. It won't change much. What would change, though, is the players that are in the game. So I want to draw your attention to some of the things that we've seen happening here. If you look at the chronic diseases that we're seeing in Africa today, these are people who have HIV. I trained as a medical resident in the early 90s in New York City. The ground zero for HIV was Bellevue Hospital. That's where I see patients. When you think about that time, when we see patients, it's like we know they're going to die. It's not the question of will they die? We know they will die. The question was when will they die? Today, people are living much longer. And so that is something that we're going to have to think about. Beyond that, we have to think about, I don't like the term, but I'll use it, the idea of the non-communicable diseases. You will never hear us tell people in America that they have NCDs. We name the disease. Hypertension, is diabetes, is high cholesterol, is kidney disease, is dialysis, is cancer. But for whatever it's worth, the NCDs we're seeing today is a huge growing burden, and somehow we don't talk about them enough. But we think we have the platform to actually make that happen. So all of that to say that the infrastructure has been built is actually supposed to help with advancing the work in that space. Again, sharing some numbers with you, bringing this home to the kind of work I do, mostly focused on hypertension. The most important diagnosis today, anywhere in the world, is hypertension. About 1.2 billion people have high blood pressure. A whole lot of them don't even know they have it. To me, I call it the gateway to how we manage disease. If you look in Africa, when I was born, prevalence was 5%. Today, it's 39 in Nigeria to about 45 if you look at blacks in South Africa. We're talking about a very young population. What that means, in my opinion, is that we cannot talk about global health without talking about the chronic diseases that actually affect people. Because the life lost and the disability from that is huge. So when you look at these numbers here, it's actually scary that across the world today, we're going to see a rising burden of high blood pressure in younger populations. Our guidelines today talk about people 30 years and older. WHO guidelines talk about people 40 years and older. We're talking about 18-year-olds, talking about strokes getting much younger, and we don't capture them enough. So it's important for you to have that context as we have this discourse around the debate we're having today. So there are three things happening when you think about the epidemic of any chronic disease, but let's just focus on hypertension because my exemplars will come from there. One is there's an ongoing demographic health transition. I just talked about that, right? We've moved from agrarian populations to now become major consumers of processed foods. We've moved from really the idea of massive agriculture to now becoming much more industrialized. The problem in Africa is that we actually are getting also older. And so because we're getting older, we're seeing a massive shift. The second thing happening is also that there's a poor infrastructure when it comes to the idea of actually how do we think about healthcare systems. I don't like the word underdeveloped. It's just simply poor. But think about it for a second. In the 60s, okay, as when I was born, vaccination problems were never an issue. Today they are. The primary health centers are still there. They haven't changed from the colonial era. So you have to ask the question, what happened in those 60 years in between? I think we lost faith in public health. Public health was everything. Yet, we spend, I don't know, $6 billion we heard today from the PEPFAR funds or USAID every year, malaria funds, inordinate amount of money. When you think about the progress we've made in that space, not so much. I think we did not focus on the infrastructure. And I think it was Kelly that said that, about the whole idea of building that strengthening of the healthcare system. So we're seeing a rising population, we're seeing a huge growth, and we're seeing a rising burden of disease in the context of poor infrastructure. And finally, there's a critical shortage of healthcare workers. So I was one of those that actually, we call it, they call it Japa syndrome in Nigeria today, but we had a different name. We call it Andrew Don't Check Out in the early 90s. I've been here for 35 years. So I live in both worlds. So I do go back now 4 or 5 times a year, but we still have that critical shortage. When we talk about critical shortage, I want folks to take a step back and think about this. Most of Africa actually was colonized by the French. We had the Portuguese play some action there, then the British. The entire National Health Insurance Service, or National Health Services in Britain, was actually funded by the Commonwealth. When we talk about brain drain, it's been happening for over 60 years. Every single doctor, physician in the British Caribbean, West Indies, as they call them, or in Africa, actually had to spend 5-7 years in England. People forget that the NHS is actually funded by doctors from the colonies, as they would call them. So the idea of brain drain is not new It's always been there. We're just repackaging how we talk about it. I am actually less concerned about this because, as you see on the next slide, with all of these shortages we're talking about, we're beginning to see the same thing happening all around the world. In the US today, we say we have a deficit of maybe 164,000 doctors. Yet we have a policy that is actually affecting immigrants. About 25% of doctors are foreign medical doctors, and so we have a problem there as well. Even beyond that, the shortage of nursing is just incredibly mind-boggling. So we know there's a shortage of healthcare workers all around the world. The difference, though, is that when you look in the African context, we're really saying that the global health funding that's been reduced will actually worsen that shortage of healthcare providers. Now, I want to draw attention to a few things here, which I think will also be my closing remarks before I get to the other part of the talk. Let's not forget that the amount of effort that we've seen from the African continent when it comes to global crisis has been short of incredible. If you look at the Ebola crisis, okay, we thought it was going to wipe everybody out. Actually, I was in Ghana. I went to Lagos briefly when that happened. And what you see is that we evolved with all kinds of monitoring surveillance systems that is being used all over Europe today and most of Africa. You look at the AIDS epidemic, they're still there. And then most recently, look at the COVID pandemic. There's a lot of things happening there. And we're seeing some kind of reverse innovation. I think this is where we need to sit. This is how we need to refocus the question we're talking about today. I think it's crucial to appreciate that if we talk about the Armageddon, it's always been there in Africa. Colonialism was an Armageddon, but people still live. Ebola was an Armageddon, supposedly, it's still here. COVID was one. They had less deaths, it's still here. So the idea I'm saying, to begin to drum up with you here, is to think about how do we build on these successes and what are we doing in that space of the success. It turns out there's a concept called reciprocal innovation. When I sat on the Fogarty board for 5 years, the idea was, can we think about reverse innovation? And often we tell myself, there's a way with English language that actually is kind of interesting. You look at the word, it makes it look new. It's actually not new. But the components of it is not something we talk about enough. Because every time we talk about Africa, we talk about charity. I believe the same will be true for Central America as well. But I think it's important for us to think about these components of reciprocal innovation where we can actually have bi-directional way of doing work. The entire premise of Mount Global Health work is actually focused in that space. And I want to share some exemplars with you and hopefully challenge you on some thoughts about this. So on this slide here, what you see is in 2011, the United States NHLBI, Grand Canada Challenges, the Australian governments, I believe the Chinese government as well, they came together and they said, we're going to form something called the Global Alliance for Chronic Disease. To give you historical context, at this time, the idea was that people with HIV were living longer. There was significant success, just barely 12 years out of the PEPFAR funds, where they were seeing significant improvement in life expectancy for HIV folks. But the WHO somehow, they didn't have the political will to advance funding for NCDs, as it was called. So the Global Alliance for Chronic Disease came out of that. And they were going to fund several studies to begin to look at the implementation science, the idea that if we truly have the evidence, what exactly is stopping us from implementing those evidence? Of course, WashU plays a huge role in the space of implementation science. So of course I applied for those grants, and I got one of those. And the premise of that study is actually what you see here, is a task-shifting strategy to control hypertension. In 2002, the WHO came up with a task-shifting strategy policy for HIV care, because it was obvious that you don't have enough docs, you don't have enough ID docs, but you have good nurses that can do the job. So countries came up with policies, but the adoption of those policies wasn't clear. So we tested that in Ghana. And then we used data from that to say, okay, can we really see what is happening in Brooklyn? In Brooklyn, NYU Brooklyn is a safety net hospital where we have I think 80% of the population in Sunset Park actually are on Medicaid. To me, is the highest density of Medicaid in the entire country. People don't talk about it enough. It's in Brooklyn. The idea, though, there is that how do we provide care for immigrants? 40% actually, they're either Arabic or Hispanics, about 5% African Americans, and then you can fill in the gaps with other ethnicities in New York City. So how do we really take care of people there? We took the work we did in Ghana, and we applied it here to NMHD to actually begin to look at task shifting strategies for hypertension control in the FQHCs that are part of NYU. And then we came to say, okay, we did that well. What about practice facilitation within our faculty group practice? And then obviously, we began to then look at how we begin to take that same approach to look at integrating hypertension care into HIV, really building that platform. So for the very first study, what we did was, to say, what are the components of the task sharing strategies? I put this here just for the students in public health to appreciate that. What you see on this slide, with all of the bad vibes from WHO, is the fundamental basics of what we call team-based care in America today. Again, it's all nomenclature, right? So the idea is that we know that, for you to actually take care of people, you've got to figure out how to provide rational distribution of tasks among healthcare workers. So if I'm seeing a patient today in the healthcare setting, there's something we call the RVUs. That means I must be able to see patients based on the values and the time that's allotted to me. All I have is 15 minutes. Your hypertension will never be treated in 15 minutes. That won't happen. Now, if you have heart failure, good luck. I don't know how Dr. Hoffman, Dr. Davila does it. It's very difficult. But if you have a team that sees that patient, medical assistants, before they come to see me, we've addressed all the issues around medication adherence. By the time they're seeing me, we're just going over your results. So the idea becomes, you've got to figure out a way to distribute that task rationally. And this is useful in healthcare settings that are actually suffering from major resource deficit. But the same is true for a healthcare setting that has major funds. Why? Because we're seeing more and more patients within the healthcare system. Number three, we've got to figure out how to really optimize this strategy to address the critical shortage of physicians in Africa. In Nigeria, you have one, we're not doing badly, 1 to 5,000 or 1 to 600, some people will say, depends on where you live. In Tanzania, 1 to 50,000. Country is only 60 million people. In Ghana, it depends on where you live. You're in Accra, maybe 1 to 10,000. If you live in Kumowu, that is 1 to probably 50, 60,000. So the shortage is real. But if you live in Appalachia here as well, the shortage is also real. You're looking at 1 to 10,000. So it's not as if this is the same all over the world. Rural America has the same thing. So you begin to ask yourself, how do we really address this? So this method of implementing primary, secondary prevention at the primary care level becomes very important. And then finally, the idea is that all of these structures can be supported via some policy. For hypertension at least, there is policy for team-based care, at least in the US. In Nigeria, in Ghana, there's a policy for task shifting. So building upon that policy, we then say, can we ask the question, how do we treat hypertension in those settings by having nurses to treat them? So the first study was in Ghana, and we did that in the central part of Ghana called the Ashanti region. We took 30 healthcare centers, we randomized them actually. It's a cluster trial. One group got health insurance plus task shifting, the other got just task shifting alone. We could not give people something because health insurance was already free. And if you remember, the health insurance in Ghana was national. You paid just some small copay to actually achieve care. And what we found was phenomenal. The first time in my entire life of doing all of my studies are actually negative. Prior to this time, all of my trials were negative. I'm serious. I became a very artful descriptor of negative trials until the study in Ghana. And then what we found there was that if you look at the data, really, we have 2 interventions, health insurance coverage, then addition of TASH. That's task shifting strategy for patient control. We train the nurses, it takes about 3 days. I think Professor William is somewhere in the audience here. She was actually one of our grad students, I think it's Sarah Stone or Sloan, Blackstone, was actually working with us on this grant. And so what we found was that if you look at the systolic hypertension reduction, it dropped for both groups by about 16%. For the intervention group, about 20, not 16, 16 points. Intervention was about 20 points, and this was sustained 24 months later when we left. Now, if you look at our clinical trials here on hypertension, we rarely see this amount of drop. Now, the key here is that these are patients who are naive to treatment, so we expect that to be that case. But to this level was really huge. This became my first positive trial. I actually printed this paper, and I looked at it for days because I had to be sure this is real. And then the next thing then became, what do we do with this? Where do we go with this? We then said, okay, about the same time, we're having problem in the federally qualified healthcare centers. You probably heard about them. This is where low-income patients actually receive care. They have significant comorbidity. Can we do a similar strategy in the US, in Brooklyn, in Sunset Park, doing exactly the same thing? But what we did here that was a bit different with Alta was to say, what if we train the medical assistant and we have that assistant do the counseling for patients around medication adherence? By the time that happens, by the time you're seeing your doc, we already know the problems you're having. By the time the doctor sees you, the nurse case manager already has a sense of what is going on with you. We have home BP monitoring, and we initiated that study by Dr. Schoenthaler, who is our associate director for research in the Institute. And this paper was published, and it became really a tool of how we do this work. And now at NYU Langone Health, we have home BP telemonitoring that actually allows us to leverage this infrastructure. And then you fast forward, we began to say, this is the Alta study. We began to then ask the next question. How do we actually scale this up? Not just in FQHCs, but in other practices. And this is where we then said, can we look at this study? This is a U grant. It's a 7-year study. It's now in the 4th year. That means I'll be nearing Medicare when this trial finishes. I'm very happy. That means, we can do more work. We looked at now not just the FQHCs. We now came to our medical center, the faculty group practices. The problem with the faculty group practices, and the NYU Langone Health is number 1 in quality and safety, is you got 8 minutes to see a patient. The chief clinical strategy officer called me and said, Gbenga, we like your study, but do not F with our workflow. Just so we're clear, the workflow becomes very important. Now you talk about implementation science. That was obvious to me already. I said, Andy, we can save time, actually, if we do everything remotely. So we spent 2 solid years studying the system, our system, to appreciate how do we take stuff that we're doing in the family health centers to bring it here. Ultimately, we reach a situation where we say we have remote blood pressure monitoring, we have 1 centralized nurse case manager, and then we're going to address the social determinants of health or patients' health-related social needs. If we put you on these 2 and your BP is uncontrolled in 6 months, we trigger community health worker. We then work with that patient to address the major goals they have in addressing this SDOH. And then hopefully, what tends to happen ultimately is that your BP should be controlled. It's a stepwise trial. We're in our 4th year now. We have 2 more years to go. But then, as we were writing this grant, I met a wonderful human being called Professor D.K. Oji. And what DK did was actually presented this major trial at the American Heart Association, American College of Cardiology. I was the moderator. And it was a Creole study. They had done studies in 6 African countries to look at combination therapy for hypertension control. So I walked up to him and I said, listen, hypertension is great, but the real problem is HIV. We can do all this stuff with people, but we've got to figure out how to leverage the infrastructure that has been built by PEPFAR and build upon that hypertension work. So the MAPI trial is doing exactly that. We just rounded up in August. Dr. Wilumor, myself, and Dr. Oji are MPIs on that grant. And the findings were incredible. All I can tell you is we have significant reduction in systolic BP control. And BP dropped by 22 points. And we're looking at the same maintenance in 24 points, in 24 months. It's under review as we speak. Again, the idea is to take practice facilitation, which is what we did in New York City, to take it there to improve TASH by using practice facilitation. And this is still a lot of Dr. Oji is right here in the audience. He's a cardiologist and does a lot of work. And now the Nigerian Congress, actually, they're going to look at the policy and how to shift that. He's done much more work with Dr. Hoffman in that space around salt reduction as well in the country. And then you fast forward, myself and Dr. Wellum also are doing some work in Lagos in a program with the National Medical Research Institute, doing a similar study. So I started these two studies at two different times. One is a stepwise design, the other is a cluster randomized trial. The results are strikingly the same. So the point I'm making with these studies is that we can take what we've learned globally, we bring it locally, we refine it better, and then we go back globally to see how we can make this work. And so the next stage then becomes, what should we do? And this is where I want to spend some time to talk about the call to action. I believe 4 things have to happen. We need to think about how we highlight the advancement in the global south. I think we have to stop. I mean, my oldest one calls this trauma porn. We talk about problems all the time. I see this in health equity research. I tell my colleagues, I don't want to hear more about health disparities. We know that it's been there for 100 years. The question is, what are the drivers? Now we know what the drivers are. The question is, what are the interventions? Now that we know some sense of solutions, the question really becomes, what are the structural policies that can help us at least mitigate that? If you look at the US context. If you look at the global context, I think we have to start really talking about the solutions we've put forward. There is a lot that is happening on the continent that we must talk about. And I think that is what this message is saying. We've got to highlight all of the advancement in the global south. The second thing is that we have to train the next generation of scholars actually locally. So before I joined the Fogarty board, when you look at all the training programs, I'm not going to mention countries here, where you have, in one university, you have 5 training grants. They've only trained 10 PhDs. After 5 years, you got to ask yourself what is going on. We evolved a program called CART, where we bring 20 professors from here, they come to Ghana, we train them, we train the Nigerians, and then we improve healthcare. But we leave them there to do relevant research. I think that's very important. Number 3 is the idea that reciprocal innovation actually works. We should use data from both sides. We need to really focus on where the solutions are. I know it's very dark these days, but Dr. King said, rather than curse the darkness, we should light a candle. I think it's important for us to focus on where the solutions are. And then finally, changes like this will happen again, but the way we tell the story is what's going to be very important. So on that note, I want to talk about some things I think are crucial. This is Chino Achebe here, talking about no one should enter their house through another man's gate. I think the story that we have to tell has to really be related to how much work we're doing on the continent. We can't keep creating solutions that are largely dependent on funding from abroad. And he also said something here that, about the idea that until the lions actually tell their story, the story of the hunt will glorify the hunter. I think this is important. We wait for the problem to be designed in the global north. And then they come to you and say, here's what you're going to do. And they actually manipulate the funding. You heard about that from the panel today, to make it difficult for you to actually find the solutions. I think we have to speak more, speak loud. I've been told to stop, but I'm a keynote speaker, so I'm going to take 1 more minute. I know Dr. Hoffman will not mind. But I think here, Ampatiba, really does a good job of talking about the hand that gives dictates. So I'm not surprised at where we are today. The problem is we've not created solutions that allows us to begin to solve the problems and define them ourselves. I think when people give you money, you got to be careful. There are conditions attached to that money. You've got to take that money eyes wide open. And I think this is the point of this slide here that I just evolved in September of last year. When I thought about these things, I don't know any country that has achieved prosperity through charity. What they've achieved is dependence. And that's the era of colonialism. And that's why we're here today, 60 years later, post-WHO. We're still begging for how we look for solutions. We don't even talk about the solutions enough. I think that's very important. And then finally, it's important to really have hope. I think in Things Fall Apart, there's Eneke in Tioba. It's a bird that's supposed to signify wisdom in the Igbo culture. My wife is Igbo, and this is where I learned to speak Igbo myself. And the idea here is that the bird says, since men have learned to shoot without missing, he has learned to fly without perching. The idea here is that we've got to be adaptable. We cannot sit and lick our wounds. If I was a public health student today, if I was a public professional today, I would think about where is that solution going to come from? And we really have to adapt to that solution. It's important. The best way to resist, in my point, is actually to adapt. I still run a center, Institute for Global Health, and health equity is still there. And we're still doing the work. If anything, we've done more work than we did actually 5 years prior to when COVID happened. So with that, I want to thank everybody and say that ultimately the reason we're here is to solve a problem. Again, Kingsmen, when they gather under the moonlight to have dinner, it's not because they cannot see the moonlight from their heart, that's the OB. It's because they have a funny problem to discuss. I'm hoping that in the next 40 or so minutes, we have time to discuss the funny issue of global health. Thank you for your attention.
Wow, thank you very much, Dr. Ogedegbe. Well, I'm excited to continue this conversation and invite some panelists to join me up on stage. First, I'd like to invite Diego Abente, who's the president and CEO of Casa de Salud. Round of applause. Next, Margaret Crook. She's a distinguished professor of health systems and medicine at WashU Medicine, secondary faculty of WashU Public Health, and director of Quality Evidence for Health System Transformation Quest Center and Network. And last, Kim Tweedy-Seelinger, professor of practice and director of the Center for Human Rights, Gender, and Migration at the WashU School of Public Health. So everyone on this panel has helped. Everyone on this panel has helped shape health policy or practice at local, national, global levels and can speak to the link between how global lessons or initiatives can strengthen health in our communities. So I'd like each of the panelists to maybe give a brief introduction of their work and how it relates to the panel's theme. So Diego, I'll start with you.
Good morning, afternoon, I guess. Again, Diego Bente, President and CEO of Casa de Salud. I hope to bring the practitioners' perspective to this very exciting conversation, a very local perspective as well. Casa de Salud is a nonprofit that's based right here in St. Louis, in the city of St. Louis, and our mission is to provide access to primary health care and mental health care, and do it with quality and dignity, and provide that care to people who are under or uninsured. And in today's world, in today's nomenclature, we're using under-resourced, right? On the margins of being able to access care with very little hope in accessing that care. And the people that we serve primarily are newly arrived immigrants who, in addition to the very sort of standard and historical and well-versed barriers to care like transportation and complexity and cost, also layer on top of that barriers to access because of their culture and their preferred language, which is not English, which is not the culture that we learn naturally by being in the United States. And so CASA has spent a lot of time learning and understanding the needs of this community, of humbly asking this community what we can do to respond and to serve their needs, and then helping them, most importantly, transition and bridge into mainstream healthcare systems here in the United States. And I say this, and I'll tie into, I think, what Rodrigo said earlier. Immigrants come to the United States, and I'm an immigrant from Paraguay, very close to where Rodrigo grew up. We come here to the United States being told that there's hope and there's access and there's resources and there's opportunity. And oftentimes, once we're here, we're greeted with a lot of barriers and challenges that we weren't expecting. And we're greeted with the strangeness of trying to understand that experience through the lens that we grew up with in our home countries, and no real roadmap to how to navigate this country. And so it's important to keep that in mind as we're thinking about transferring the global perspective and experience into the local perspective and experience, because there are so many similarities in terms of how we sometimes design interventions in a laboratory and expect them to work in reality without ever conferring with the reality that's just outside the laboratory where these interventions were developed. And so again, I hope that on this panel I can help to share some of the experiences we have here at CASA and with the patients and the clients that we serve to provide some context to the conversation about how we can think about research in the public healthcare space, about resources in the public healthcare space, but more importantly about the human beings that we are trying to serve and their experience and what they need from providers and researchers and from the resources that are available to serve the needs that they have.
Thanks, Diego. Margaret, can you tell us about your work and how it relates to the panel's theme?
Sounds great. Thank you so much, Mark. And thanks everyone for being here and joining us today. I loved your talk. I just loved it. I'm Margaret Crook. I'm a professor of health systems and medicine. And I briefly will just say something about my work, but really mostly I just want to reflect on what you've talked about. I've been studying health systems. I'm a physician. That was my first job. And I've been studying how health systems work, how they can work better my entire career in one way or another. Only some of that career has been in academia. So I bring to academia sort of the perspective of a clinician, a consultant, a skeptic, and I think that's really informed a lot of our work. And that work has really been to understand the distance between rhetoric and hope on the one hand of what health systems should deliver and do, and reality on the other hand of what they actually are doing today. And it turns out that that distance is pretty vast. And it's big in low and middle income countries where I've spent the majority of my career and have had the greatest privilege really of learning from colleagues, mostly in East Africa, but really throughout the continent. But also that gap is quite large in this country, in this city, in my former city, in all the cities, in New York and elsewhere. And so the aspirations of populations are not hugely different in terms of what they would hope to get out of a healthcare visit, but often they don't get that. And then, of course, the health outcomes suffer. So that's what I work on. But I really want to turn to Dr. Ogedegbe's incredible presentation and pick up on a couple of themes, I think, that unite our interests. And I was trying to think of what's a way to describe your particular take on this moment and on your research and kind of as we look forward to the future of global public health. And the term powerful, pragmatic public health came to my mind. So I think you're acknowledging, and the previous panel also acknowledged the power of public health and the continued need for public health. None of the needs have gone away, despite all of the pummeling that public health has received over the last years. But I think what I'm hearing from your presentation is the insistence on pragmatism, hope, and optimism, all of those things. Instead of bemoaning the failures, the gaps, the losses, we don't assist anyone by dwelling in that space. What we instead can do is confront the situation that is in front of us, particularly the pragmatic experiences of people receiving healthcare, and as researchers, figure out how can we move that forward? How can we push that and advance that from not where we would like to be, but from where we are actually, right? So I just want to point to maybe three topics that you've raised and maybe just reflect on them. I love some of the examples you gave, right? And I love also that the examples came from everywhere. There are issues in Brooklyn, there are issues in St. Louis, there are issues in Lagos and in Dar and in Addis where I've been working. So here's one issue that we've identified in our People's Voice survey across 25 countries. When we ask people what is the quality of care, and we ask them for different elements of care, one of the interesting common pain points for users of health systems is that the front desk staff are mean. They're mean, they decrease the value of that healthcare experience. So we could dwell on that, we could talk about re-education campaigns, we can do all sorts of things, wring our hands. But I just want to point out why that pragmatic observation is so important, right? Because most of our work in health systems doesn't focus on front desk staff. We're thinking about doctors, maybe nurses some of the time, right? Maybe community health workers, okay, but we don't think about that. And so in your presentation, you showed us how we can engage health assistants, maybe receptionists could get in on this action too, and start to engage with patients coming in to, hopefully, let's start with treating them humanely, but secondly, maybe actually engaging and helping them with their own care, with self-care, with remote monitoring of blood pressure or whatever it is. So I love that pragmatic approach. And if we can find a way to make those jobs meaningful and satisfying and the patients feel valued, that's a win-win and a win, right? So that's one pragmatic approach that doesn't, yeah. The second thing you talked about, again, one of your studies echoes one of my studies from maybe 15 years ago. You talked about how do we use the PEPFAR platform to deal with, and I loved your point about non-communicable diseases. Nobody in this country says that. We actually name the disease. Let's not lump. Let's be specific about what it is we're trying to achieve, right? I feel the same way about maternal and newborn health. I've often made the comment, nobody in this country uses the word BMONC or CMONC. Looking to see how many people's faces even recognize those terms. We don't use them. No obstetrician has ever said basic emergency obstetric care. There's just the one good obstetric care for everybody. Nobody gets basic, and some people get non-basic. So I just think let's give the same respect to people and conditions across countries and not lump them all into one, certainly not from a health systems approach. So your work is saying, look, we've got a platform, it's been built, again, a pragmatic observation. Is it the very best platform? We've heard from Kelly that it's probably too expensive and overly cumbersome, and I would agree. I've studied PEPFAR as well. In our work 15 years ago, we tried to understand whether what PEPFAR has created, however, can draw more people into the health system. Are there collateral benefits for delivering mothers, for example? And we found that yes, HIV-negative mothers come to those clinics where they can observe higher quality of care. It gets them out of their home and out of subpar clinics into better clinics, and that's a win. That's a win for the system. And again, starts with where the health system is, not where we would like it to be. So I love that. And then I just want to end by saying, I appreciate, I think, the way that you wrapped your presentation by saying, look, as tech solutions, there's lots of solutions that we have to contain and describe very clearly in order to be able to test them. RCTs cannot be done on, massive structural change. And yet I think you called for structural change at the very end. You said, yes, we can improve our tools, we can improve our approaches, we can improve service delivery models, and we must, actually. But at the same time, and I think this echoes some of the themes of the first panel, what we really need to be thinking about is what are the structures underlying, what are the agreements and the values underlying decisions made about health systems? And by the way, who's making those decisions? I do not mourn the passing of USAID. I do mourn, and I think is morally objectionable, the way in which that happened. A massive transformation in how we deliver aid, is happening not just in this country. It's not just about Trump. Somebody pointed out in the first panel, global funding for all of health assistance is going down dramatically, probably by 40% in the next 2 years. It's not just a US issue. Countries everywhere are reconceiving what it means to donate resources, and recipient countries, they won't say it in the moment because of course they're suffering a loss, but within weeks, the government of Ghana was able to repurpose some of their health taxes, be able to get a larger proportion of their health taxes back into the health system in a way they weren't under the previous regime. And Ethiopia was able to enact some new health taxes to fund its own health care. So I am hopeful. I do not think the way we did it was right. I am very hopeful, however, that the ingenuity, the intelligence and the creativity and purpose that is there in the continent and throughout will see this moment through and hopefully will minimize the kinds of consequences that we fear.
Thanks, Margaret. Kim, can you introduce your work and how it relates to the theme, please?
Yeah, I'm happy to, Mark. So I'm a little bit of a poser here. I am a lawyer. I'm a lawyer by training, I'm a lawyer by practice, but I've spent a lot of time, the last 15, 20 years, working in conjunction with public health colleagues. And so let me situate myself in this conversation. I'm a lawyer who sees public health as really central to access to accountability and justice processes. And I'll explain why. So when I went to law school, I was at NYU actually for law school, and I went there specifically because of the international sort of social justice programming there. My third year of law school, which is when you're getting ready to graduate and move out into the world, I'm going to school in downtown New York, and the World Trade Center is bombed. Like 9/11 happened within the first 2 weeks, right, of my third year of law school. And so I had to pivot from my focus on international human rights work to commit myself fully to something I'd never done before, never thought about before, which was deportation defense, because it was very clear what was going to happen with our measures and how it was going to silence low-income immigrants by boroughs of New York. So I did that because it was a way to be useful as a young law grad. But what was really humbling for me, I come out of law school, I think I'm really smart, I think I know the immigration laws, was the number of issues that my clients came to me that were actually about health, which I had zero training on. Whether it was because someone had come to the United States in order to flee homophobic violence back home that was really causing them physical and mental harm, or had been in the United States for a long time, but leaving and being deported from the US would mean their child couldn't get like necessary health care, for example. So health was central to everything my clients were coming from. I had clients who had suffered female genital mutilation in different parts of Africa, including in Ethiopia, right? Or I had clients who had suffered forms of sexual violence that had, caused them to become HIV positive, for example, and they wanted health care even more than they wanted legal representation. And so I had to learn to collaborate. I had to learn to understand the health conditions my clients were coming to me with. And that was a bit of a christening by fire in the beginning. And since then, in the last 15, 20 years, I've shifted more back into international human rights work, specifically international crimes. And health continues to be central to the question of accountability and justice. And this is now, I'm talking more at a population level for a lot of the things that I work on. I work on war crimes, crimes against humanity, acts of genocide. I'll give you an example from genocide. Genocide, I teach this here, it is a crime that the central to it is the intention to destroy a group in whole or in part, right? And the group is bounded by ethnicity, political opinion, religion, for example. There are only 5 buckets of conduct that can constitute an act of genocide, right? We all think about killing, obvious, mortality is the health implication there. But also the other 4 acts, most of them are directly expressed through violations of health, right? These are measures imposed to prevent births within one group, right? Or it's the imposition of conditions calculated to destroy this group, right? So things like that, or infliction of serious bodily or mental harm on a group. The only act of genocide that is not explicitly and patently health-focused is the illegal transfer of children from one group to another, right? Everything else, the expression of the violence is absolutely a violation of health, first and foremost, right? So I have been spending the last couple of years working at the International Criminal Court. I took leave from WashU for a few years, working on gender-based crimes and crimes against and affecting children, where health remains central to the expression of that violence and elements of those crimes. Some crimes are direct, health is on the face of it. Other offenses, health is impacted in a downstream way, right? Like some are obvious, the war crime of using starvation as a method of war, or forms of sexual violence that may render you infertile for the rest of your life. That's on one end of the spectrum. But then you get to crimes like persecution based on gender that manifests as denial of girls' education. On the face of it, it's not a public health question. 2 layers down, it absolutely is, right? So that's what I've been working on. And that is why I think that when we talk about global health, we have to also see justice actors as part of that conversation. It's debatable whether these trials have any preventative or deterrent value. We like to believe so, but the evidence is mixed, right? But it doesn't matter, because survivors of population-based violence, at some point, some of them are interested in legal accountability, right? And we have to make that possible for them, and make sure that those processes are thinking about public health in the process. Otherwise, we will fail to fully capture and understand the violations that they've experienced or the near and the long-term health consequences of that violence for them at individual and community levels. So if we accept that violence is a threat to public health, and I think we should, and many of the lead scholars in that are right here in the room, we have to see justice actors as part of that public health conversation globally and locally. So that's why I'm here. Thanks.
Thanks, Kim. Very glad you are here. Diego, can you talk to us about what is the experience of your clients right now? I mean, this is a pretty difficult time for a lot of people coming through into the United States, fears of deportation. They're trying to seek quality of care, if you sort of alluded to, but can you tell us kind of like what does that experience look like, feel like, and maybe try to help us understand where you've seen hope in this process?
That's deep. I'll try to do it justice. I've been in the States off and on for most of my adult life as an immigrant, and naturalized during the first Trump administration because I felt unsafe. And by comparison to the way I feel right now, and I'm a person of a lot of privilege relative to the people that we're serving at Casa de Salud, that level of lack of safety pales by comparison. One way to sort of share in a sentence how dire the situation is for immigrants that are currently in this country is that the most dangerous place for them to be right now is in transit. Anywhere. To church, to the supermarket, to your healthcare organization because you have an appointment, to work, to school, it doesn't matter. And so that informs every other decision that they have to make in a given day. And so if it's true that you feel unsafe just going from point A to point B, then what is the most important place to be if you have to travel? Unfortunately, for the sake of their health care, they oftentimes don't feel like that is at the top of their priority list, right? Number one might be going to work or to school or to take my kids to school, maybe go to the supermarket because it would be nice to have some food in the refrigerator and on the table. But I can deal with whatever's happening with my healthcare or my mental health care, which is certainly being affected by the narrative in our country right now. That I can handle myself until things get acute. And so then what we find at Casa is that when someone does come through our doors, that they are already sort of progressing in their medical or mental health care journey to a point where it's almost to the level of acuity. And Casa is set up to be a front door into the healthcare system, not to be a medical home. And so our desire is to ask where does it hurt and can we help, and to serve their immediate need, and to quickly then transition them into the mainstream healthcare system with whom we communicate often and advocate with very often so that they can receive them, understanding the challenges that they bring, understanding the hope that they have, that they're here in this country that is going to provide for them a level of healthcare and mental health care that they could have never dreamt of in their home countries. And in spite of all that, they find that they are seeing some of the very same challenges, the very same roadblocks that they have fled their countries in order to find more opportunity from. And I think two more things I want to say here before I get off my little soapbox about the experience of immigrants right now. It isn't said enough that the people in this country, regardless of where they've come from, they just want to give back, contribute, whether that's their family or their neighborhood or their school or their workplace or their place of education. I think it is an innate human nature to want to give back and to want to feel proud that you were a part of a tribe, a group of humans. Immigrants want to do that just as much as anyone else. And in order to do that, or in order to do that at its highest level, it is very important to feel good, to be well. Whether that's physical or mental wellness, those things are the foundation, the bedrock upon which all that giving back happens. My entire career has been shaped by my desire, because my parents came here in '78 before the Refugee Act passed, but ostensibly as refugees, to paying back and giving forward the opportunities that my family received. When I came here, I was very fortunate. I was young. I picked up English more or less a little bit, and I look fairly normative, and so I can pass. But I will never forget how hard it was for my parents to build that foundation upon which they then taught their children to think about how fortunate we were and how important it was for us to give back. And that's what immigrants are trying to do right now, and they cannot because they are being roadblocked, and they're the very foundation of their, upon which they're building this desire to give back, the resources and the assets, both tangible and intangible, to give back are being taken away from them. And that's very, very difficult. I'll say one last thing really quickly about sort of what we can learn from the global experience and the national and the local experience. I spent several years in Equatorial Guinea providing malaria prevention and behavioral health interventions, and many of the same challenges that I saw there as an American, as a non-native, providing, non-in-country person providing care are similar to the ones that we hear about now. So for example, mean front desk staff, people who don't understand the experience of those walking the door, who are in a hurry, who are on a timeline. The system is driving that behavior. But on the other end, the people that we want to serve are bumping up against that and thinking, well, you don't care about what I want to bring. You don't understand how I'm feeling, what I'm feeling. We agree that I don't feel well. We agree that the medical intervention is necessary, but we don't agree on how you are allowing me to express that feeling that I have. And that, again, is the foundation of good healthcare, because at the end of the day, what happens in the medical space is a fraction of what is required from us to stay healthy, to remain healthy, to continue to be healthy. And so those lessons learned, I think, are crucial as we think about how in this resource-constrained, very politicized moment, we tend and provide care to each other.
And tell me about the hope. I mean, how it's dark, it's hard. What is getting you a ability to get up and do the work? I mean, probably your commitment to the cause.
I didn't answer that on purpose. There is none. I'm kidding. Certainly the community. I've had the privilege of coming and speaking here at WashU many times. Here in St. Louis, this academic community, these young people that come to St. Louis to learn how to do well, how to do good in life and do good for their communities is certainly inspiring. And we have the opportunity to interact with them at CASA, and that really provides us energy. I think also hearing from our patients and clients who are so thankful that we are still here, that we are still listening, and that we're not trying to tell them what's right or what to do or where all the solutions are, but simply let's just hear you out and let's figure out together as a team what we can do to move you forward in your either healthcare or your mental health care journey. And I think that's really important, that humility, that we don't have all the solutions. Even in partnership, we can't provide all of the solutions, but we can certainly start to think about what the problem looks like, contextualize it, sort of draw out the framework of the problem, and then together we can design solutions that over time not only are effective, but also sustainable.
Thank you. Thank you. Gbenga, you've focused a lot, like when you are visiting, you said, I want to meet with early stage investigators. And that as a deep commitment that you have to capacity building, helping the next generation of scholars and students. Tell me about a little bit where that comes from, but also the advice that you're going to be giving some of them who will be meeting with you. This feels like a difficult time to be pursuing global health, public health, academia. So again, I'm going to ask you, give us some hope. We need some hope, Gbenga.
So honestly, it's a great question. I live in the crosshairs right now. So my day job is to drive health equity across a very large healthcare system, right? NY Langone Health. And that's in health equity, right? So that's in the crosshairs. And then my night job is we also have a section for global health, which have faculty doing work like I do in other places. So, but when we look at our data in the past 2 years, people actually have done more than they did prior to 2 years ago. So I'm like, what happened here? Productivity went up. So I call it displaced anxiety. And I think it is displaced because the hope is already there. When you're in academia, you're in need because you want to do it. I think that piece we often forget. And so my job really was to sit with people and say, look, I have something I call the 10 Gbenga rules. I'm not going to go through all of them, but there are two I think is very important. I said, one is to find the passion in what you do. So when I wake up every day and I'm going to clinic, and I'm seeing those patients when I was a resident. I trained in South Bronx, okay? So South Bronx in the 80s and 90s is not a place you want to be. But that is where I trained. So for me, it's a lived experience. So I tell people, try to draw upon why you're doing this job. Because if you can figure out what that passion is, then it's easier to have hope. If it is purely academic, I don't know what to tell you. It's a rough time. The second thing I tell people is that apart from finding the passion, is to be open-minded. I think there's a way we frame what we do that also gets in the crosshairs. So I'll be a bit more specific. So in my institution, as a chair, we have to come up with strategies every 6 months on how we'll take our health system, we're integrated to the next level. So the way I think about it is to say, okay, health equity was supposed to be dead. And we're somehow not dead yet. We're actually doing better. I have to find wood to knock on here. So the point is, I then ask myself, if I'm going to really be able to think about health equity, what will I do differently? What I would do differently is define it in a way that's supposed to be defined. We're talking about it at dinner last night. Diversity is not health equity. Diversity is the workforce. It's what we need to be. It's how we need to really show up. It's important. Somebody said, yes, I think it was Ked that said, it's necessary but not sufficient. Okay. Health equity, health, very important, is a need. So I defined it by 5 domains. I don't talk about race and ethnicity as much because we have colleagues who don't believe in it. I talked about disability. Anybody living with disability, that's a health equity issue. Our systems are not really designed to actually accommodate for those, for the most part. I talk about geography. So we have first parts of NYU. We have Long Island, we have Suffolk, which is rural. We have Brooklyn, which is largely safety net, and we have Manhattan, which is continental, right? So you can pick wherever you want to pick. There is geography there. And then the third thing I talk about is the idea that beyond geography, you really have to focus on social needs. So the way we write our studies today is to frame it, I don't know who said that, about the idea that the social determinants of health does not know race or ethnicity. It just so happens that sometimes it travels with it. There's a fabulous paper written by IHI, it's called The 10 Americas. For the EP students in the audience, please pick up that paper and read it. The 10 Americas is very interesting. If you're white and you're in Appalachia, your life expectancy is much shorter than if you're black and you're in urban America. Just let that settle in somehow. So the idea there is that it's not so much about the people, it's about the social determinants. So most of our grants are framed around that language. And I think it's important not to forget that. It's hard to really stay away from those.
Thank you. Thank you. Terrific. Margaret, can you tell us a little more about the People's Voice Survey, including the crosstalk between Missouri, where we are, and some of the international partners and places where you've conducted this? What's kind of landing, for lack of a better term? Are there any parallels of what policymakers are listening to or responding to?
Yeah, so the People's Voice Survey is our attempt to measure system performance from the perspective of the population. So we feel like this was a missing piece when we think about the answer to the question, how is the health system doing, right? We typically look at supply side data, health system data, we look at efficiency data. Economists are very much involved in these assessments. But although most health systems profess to be people-centered, or at least moving in that direction, very rarely are people actually asked, how is it going? How is it going when you come to clinic? And how confident are you that if you were to get very sick tomorrow, one of my favorite questions, the health system would be there for you, right? Because people need health systems in reality, but they also need them as a safety net in their minds. And I think this is a very important function, providing that sense of security. So those are some of the questions we ask. It's been a very interesting journey. We've done this survey, and part of what a kind of an ingoing assumption was, again, people's aspirations and expectations from health systems have many commonalities across countries. Of course, health systems look extremely different. And I don't want to paper over those differences. They're vast, they're massive, because health systems reflect societies. They reflect values and they reflect resources. So of course, there's no equity there or equality there in what people encounter in the clinic necessarily. What we find is that there are particular sentiments that group together and are very consistent across countries. I mentioned the one about the front desk staff, which is one of our favorite observations because it is just such a consistent finding. For example, one of the things that we find an interesting difference is that in countries where systems are just evolving, or just emerging, or just being built, and in fact, many of the former USAID recipients and now the recipients of some of these MOUs, we find a kind of optimism about health systems that does not exist in high-income countries anymore. And again, maybe it's not surprising, and I think reasonable people have seen true improvements. Again, part of that through some of the global funding, but really a lot of it through the actions and resolve of national governments, right? To, for example, COVID funds, to use COVID funds to build out intensive care capacity, to improve primary care detection capacity. People see some of those things in ways that system improvements here in the US just are invisible to people. They're really behind the scenes. And some of those improvements manifest as just another failed attempt to log into my chart, right? So another password update. So I think here we are just at a very different point in that, on that optimism spectrum. We have much more hope and expectation for that in lower income countries.
Is technology going to be a level setter? I mean, in this, the models of care of thinking about, as Diego said, going from A to B, well, telehealth is a way that I certainly see some of my patients, and that can partially address some of that in a crisis. Obviously, we talked about, you and I, the tools like artificial intelligence for upskilling health workers. Like, do you see this as something that is going to really make a difference, or is it more bluster at this point?
Yeah. Well, I do think mHealth was overblown as a revolution in health, but I think we're at a different point. I think COVID's taught us a lot about telehealth, as you've just pointed out, Mark. We have a paper coming just now looking at quality of care that people experience on telehealth versus in-person care across, again, 25 countries. We're excited to share those data over the next few months with everyone. But I think that with AI and with telehealth, I think we're starting to get closer to the thing that's been very elusive, which is to get an activated, educated patient in the room, and whether that's a virtual room or an actual room, to have a more equal conversation with a clinician. So it's been always a hope to, talking about patient empowerment, community empowerment, because consumers who are empowered in any service get a better deal. They do. They get a better deal. They get better healthcare quality. Or quality of whatever service. And it's been a bit of a dream, I have to say. We've until recently, we've been saying things like, well, we have to wait till all the girls get educated and everybody gets through high school, and we have all the gender related inequities closed. I do think that appropriately designed and intentionally targeted AI and some of the telehealth tools can help. It's not going to offset all the issues. It's not going to compensate for poor quality of diagnostics and treatment, but if we can get an educated and confident patient in the room or on the screen with a clinician, someone who's not afraid, right, to speak what is bothering them, whether it's mental health or something else, I think we're going to see a transformation.
Yeah, it changes the dynamic in clinic. It sure does when the patient's coming in pretty activated, pretty informed. Gbenga, you wanted to jump in?
Yeah, I was going to just say two caveats. We have a program called the Program in Digital Health Equity. Right, so the idea is this. So we're all going to jump on the AI bandwagon, no question. But you've got to think about how is it trained? How is it designed? I think this is where Tequity, Rena Marchant is at UPenn, talks about this a lot. The idea is that the tools that we have today, and the reason mHealth did not pick up, I would never write such a grant. Now we do. 10 years ago, I don't even bother, because the mHealth tools, they're being developed here, and you're going to apply them in Africa, is a fundamental flaw in intervention science, which is that the context matters. It wasn't designed in that setting, and so it will not be sustainable. FinTech, M-Pesa, on the other hand, was not designed to be a FinTech or financial tech tool. It was designed to solve a problem. And the problem was, you don't have bank accounts.
Yep.
It's difficult to find people to sign up for you. And so you solve that problem, then it takes off. So I think we have to really think about it. The second thing is that the unintended consequences of AI tools is very, very scary when you think about it. So we've got to be in that space. So there's something called the digital terminals of health. We've got to look into that, at least for the populations we're talking about.
Yeah, not just the production of AI, so the potential climate, water, energy, but also the act of using that in replacement. The relational aspect of care is pretty foundational to what care is all about. Let me come to, well, quick.
Real quick,
Yeah.
just from our experience at CASA, also understanding the cultural lens and you know, how quickly people are becoming or not becoming comfortable with using technology as a platform for and accessing healthcare is going to, you know, it's moving at different speeds for different cultures, and just keeping that in mind also.
Great point. Okay, I'm going to ask one more question to Kim and then open it up to the audience, please. So, Kim, we want to talk about justice mechanisms, and we've spoken earlier about accountability as something that lawyers do pretty well, and they think about this a lot. How are you seeing some of the tribunal work that you've done, like these systems that we've been talking about, the UN, WHO, how are they functioning, and what are the lessons in the US that could be learned from kind of the best parts of some of the tribunal work that you and others have done? And you had kind of spoken about this in our prep really eloquently, to think about, you know, these are big issues that you're dealing with. In the US, we think of this as civil rights, human, you know, sort of a different name sometimes. Yeah.
I'm at the age where I don't remember what I said in prep, so I hope I answer it as well now. Come on, Mark.
You're great. You're great.
And I haven't worked with the WHO specifically, and I don't do so much in the US courts anymore. I mean, my experience in the US courts has been mainly on appeals of naturalization denials or asylum cases, right? And that was a long time ago. So I think it depends on which justice systems we're talking about and how they consider and promote the right to health, which is a human right. It's a direct human right itself, but also a gateway to the enjoyment of basically all other human rights too. So, you know, we see tribunals taking like a very literal role in the protection of the right to health. So for example, I know many of you work in Haiti, right? So when we had the cholera outbreak, because of sort of lack of sanitation and the practices among UN peacekeeping forces, particularly the Nepali contingent that was in Haiti at the time, that was affecting communities all over Port-au-Prince and then more broadly. And that litigation was brought in the Second Circuit in the United States federal courts, because that's where the UN sits, and courts have jurisdiction over UN action there in our federal system. And that was brought by civil society organizations in Haiti and a local group of Haitian lawyers there in conjunction with law clinics in the United States to bring this in federal court here. So that type of collaboration that has to come from sort of grassroots organizations, local experts, and then can, in some cases, use US courts to protect access to human rights of health. That's one way, I think, that there is a direct sort of literal contribution there. But then we see that, you know, in our immigration system writ large, and Diego will, I think, back me up in this, under this administration in particular, we have like a pretty aggressive diminution in respect for human rights generally, but also the way we think about health. So for example, in the area that I was working on, I worked a lot on domestic violence cases, right, and gender-based asylum cases, which for many years we had fought to establish this in the jurisprudence in the US courts and made great success. And this was, gender-based violence became a grounds, really, in practice, a grounds for asylum claims in the US. And that has been actively dismantled by the way this administration has directed the immigration court system to respond to these cases in asylum offices, which puts people at risk. It puts their health literally at risk to force them to either return to their countries or stay with abusive partners, right? For the more recent work, in terms of international crimes or mass atrocities and the impact on health, this is where I've been spending more of my time recently. And it's a mixed bag how well those mechanisms promote or respond or think about health. So as I said earlier, there are some offenses, right? Some international crimes that are very closely tied or are expressly about the right to health, and we can investigate and prosecute those international tribunals, both at the national levels and at the international courts in The Hague or other mechanisms in Geneva. In the International Criminal Court, if you are successful, right, whatever the offenses are, and they're health-related often, in case of conviction, affected communities and participating victims in that case become entitled to reparation. And this is one of the main, this is a literal connection to access to health for those who participate in these cases and their communities, because reparations can take many forms in international criminal law. And the Global Survivors Fund, for example, did a study in over maybe 24 countries about the priorities for survivors of conflict-related sexual violence, specifically, for example. And overwhelmingly, the priorities for reparation in these cases was health-related. Maybe memorialization is important, maybe teaching about the atrocities in the health or the education system is important, but mostly people wanted access to medical care because of the injuries they and their family members had suffered. They wanted access to psychosocial support because of long-term mental health effects of the things they had suffered. And they wanted all of this for themselves, but also into the future for their children, because they recognized the intergenerational impacts of the violence that they had suffered in acute conflict and in the course of displacement for many. And so that is a very concrete thing that at least certain mechanisms can provide if you are successful in the process. And I think that is one area where we can learn from global health. What are the priorities? What are the impacts of violence on a community? So that can inform how they prioritize their request for reparations in the case of a successful conviction. And even before point of conviction, in some cases you won't get a conviction. The rights of the accused need to be respected. Sometimes you'll get an acquittal, which is totally acceptable if the process was clear and transparent. Public health and global health is important at every stage of the process, actually. Because if you don't fully understand what has affected a community health-wise, you can't accurately capture it in what you choose to investigate, how you choose to characterize and charge something, and how you work with individuals as witnesses, as victim participants. Right? You don't understand enough of the health impacts of their experience to address it robustly in a legal process, which is critical. And I think one thing that really heartens me, and we still have to really realize, practice this more, is in the last 10 years, both in sort of asylum and immigration proceedings here in the US, but also in international criminal justice processes, we are finally really paying attention to taking a trauma-informed approach and a survivor-centered approach to this work, which obviously it will be informed by just knowledge from the health sciences at every level, at the very local level, and then all the way up through appeals processes and litigation. So I don't know if that's what I talked about in our prep meeting, Mark, but those are my thoughts for you.
That's yeah, I mean, just to give us your perspective and weave through your experiences. When you said mixed bag, I mean, any examples of this was working, like tell us the positive news. I mean, we hear so much of the negative, but where was it working well?
So, and this is a little bit about maybe bidirectional learning. So I had the opportunity a few years ago to work with the International Criminal Court Office of the Prosecutor to develop our new policy on gender-based crimes and also our policy on children. And because the International Criminal Court is sort of, it is the international court, all of the member states in the world that are part of the Rome Statute in the international court system, they take guidance from the International Criminal Court and they're supposed to bring it and use it and refer to it in their national systems to inform their local practices for investigation and prosecution. And so we were able in the policy to really clarify what gender-based violence-based crimes look like and the relationship between sort of sexual violence and reproductive violence and other forms of non-sexual, non-reproductive gender-based violence, and clarify that conceptually and then explain what that means in practice. That has actually filtered down into national practice and at the same time allowed national courts in countries like Colombia to say, yeah, we see you, we've been doing that actually. The Colombian Transitional Justice Court is way ahead of most other courts that we've seen, even in The Hague, of course, on addressing crimes of reproductive violence And they are feeding their learning and their finding approaches back up into The Hague, which is really exciting because it is a new area for many courts to consider. Right?
Thank you. Thank you. Okay, questions from the audience? And I'll check online as well. Okay. Don't be shy. Please, Susan. And maybe introduce yourself if you can, please.
Hi. Oh, there we go. Hi, I'm Susan Borkoper here at the School of Public Health. And I guess I'm just really curious, obviously global health has changed so much in the last year plus. And I'm curious to hear you talk about, sort of like, how does research need to change to sort of confront the current reality? And I'm thinking a lot, Gbenga, about the work that you've done to sort of bring things home and then back and that kind of thing. And how do we expedite that? So it's not just on the sort of individual level, but in this like broader systems piece, which I guess I know, Margaret, is something that you're also thinking about.
Thanks.
My own take is that it's a great question and it's a fundamental one. I think when we talk about research, we often say, which question are you asking? Or what problem are you solving? The way I think it has to change is that the questions have to come from the global south. So it's interesting what global health is. When I was young, it was called tropical medicine because it's a disease of the tropics, okay? Then it changed to a more palatable term, international health, okay? Because we're going from here or somewhere to those other places. And then it became travel medicine. For those in medicine proper, you want to do infectious disease, is travel medicine. And it still bothers me and boggles my mind that today we spend so much money on malaria, so much money on TB. It's a program in the EU that, we had a debate once at the EU Research Council, and they have 60 million euros looking at what they call the EDCTP, something clinical trials network. You know what they focus on? The neglected tropical diseases. I don't know about folks that are doing this work. Where I grew up, in my village called Warri, you would think that's what they had 50, 60 years ago. It's not, we don't have it anywhere. Or we're spending $60 million because the person asking the question is interested in that. So I think the way it's going to change is you've got to co-design the questions and really think about who you're working with in the global south. That's my take on it.
Margaret, any final comments?
I would just strongly agree with that. I think that global health research going forward needs to start by asking, where do we have shared questions? Where do we have shared challenges? And maybe where are shared solutions popping up that we could now explore? Because solutions pop up whether we do research on them or not. I'm quite convinced of that. The world just goes on. It doesn't wait for us to have an R01, study that thing. But where can we add value? Preventing the recycling of failure. There's lots of ideas that look awesome, but don't actually improve health. But I think that if we can lean into strategic partnerships with maybe a few countries where the questions are equally burning, right? But maybe an idea is developing here that we could test across settings. I'm a big believer in the value of comparison, but I think we have to make that argument for the value clear in our applications.
Great. Real quick, brief, and then we're going to wrap
Super
up.
brief. Just your question was about also how we change everything about research. And I think we have to, this is my bias as mostly a practitioner, diversify our outputs too, right? I think most of the people we work with, the folks who are implementing, the folks who are in the community and really know what the challenges to implementation are, they're never going to read the articles. They're just not going to read the articles. They may not have access to the articles. Like, it has to be, like, in our grants, there has to be time and money dedicated to fully reporting back and beyond the period of the activity of the grant, right? Because the interventions, the article only captures this much. It doesn't capture what happens later. And so I think ongoing relationship, ongoing sharing of the learning and getting critiques from the community, I think, are super important too.
Great point to end with, again. Thank you very much. So join me in a round of applause for this terrific panel.
Okay, so we're going to wrap it up. We're getting to the end of the program, and I wanted to thank all the outstanding keynote speakers, Dr. Ben Meier, Dr. Gbenga Ogedegbe, our distinguished panelists, Proskovia Nabunia, Rodrigo Rice, Kelly Saldana, Diego Bente, Margaret Crook, and Kim Tui Sillinger. Also want to thank our great moderators, Salma Abdallah and Mark Hoffman. Thank you all. Among the many messages that I learned today, several stand out. From Ben Meier, I learned about the threat of misinformation, particularly in science and health, and the need to develop new systems of trust to restore and strengthen the standards for health information, and to develop strong institutions to counter disinformation. From Gbenga, the message that I liked the most was about the need to learn from the research advancements in the global south and the need for reciprocal innovation, where we have bidirectional learning. We learn from each other. I also learned the need to build resilient and diversified funding programs and to be prepared for new challenges, as this will come again. Thank you both, Ben and Gbenga, for these powerful messages. I hope that all of you in the audience found the program insightful and inspiring. For those interested in hearing more from our keynote speakers, be on the lookout for an upcoming podcast on Complicating the Narrative, where Drs. Meier and Ogedegbe will join podcast host Salma Abdallah on follow-up conversations of today's discussions. We want to continue engaging you through our Global Health Future Network. We want to hear back from you, so please reach out to us. We will continue to prioritize policy engagement, encouraging researchers to work strategically with policymakers through the research process so findings are accessible, actionable, and adopted more quickly. We will also help our community track and communicate impact, ensuring WashU scholarship is widely disseminated to improve health and reduce inequities. Finally, as I close the program, I want to thank all of you in the audience for joining today's program, for building a new era for global health, and for your insightful questions and comments throughout the program. Thank you so much.